Good afternoon, good morning, and good evening to everyone. My name is Dr. Nick Fletcher, and I'm the Institute Chair for Anaesthesia and Critical Care here at Cleveland Clinic, London. It gives me enormous pleasure to welcome you to our first ever conference that we've organised here in celebration of opening Cleveland Clinic London Hospital just a few days ago. I'm going to pass shortly on, but I first want to just say some thanks to some really important people who've made this happen. So first of all, Georg Auzinger and Luigi Camporamata, who have made a tremendous effort to get this conference together, as well as making a tremendous effort in the front line in their own hospitals. I'd like to thank Maria and Heather in education and research, and I need to thank Lauren and Alex and the entire IT team and Gail for giving us tireless support. It's wonderful to have the entire Cleveland Clinic family here and our very, very special guests. And I think that's what's felt so good about getting this conference together. So, as we are short for time in all our sessions and we need to be prompt, I need to model that behavior as a leader. So I'm going to cut short there and finally say thank you to Dr. Brian Donnelly, our CEO here at Cleveland Clinic London, who leads us all from the front, and also to Tommaso Falcone, who you may know from Ohio, and he's our Chief of Staff here in Cleveland Clinic London. And without saying any more, I'm going to hand over to you, Tommaso.
Well, thank you very much, Nick and George. As Nick stated, I'm actually originally from Ohio. I was there for 25 years before I came to London, and I'm the Chief of Staff, Chief Academic Officer, and I'm a reproductive biologist by training. So, and again, I'd like to add my thanks to everyone. Next slide, please. What I'd like to do is just to give you a couple of minutes about Cleveland Clinic and Cleveland Clinic London, and just a couple of ideas about how we're participating in the front against this virus. So for those that may or may not know, the Cleveland Clinic is actually founded 100 years ago. And there were 4 doctors here, and they inspired this new model of care, which they came from World War I in Europe, and they came back to Ohio, and they founded this concept of teamwork, which was unique at the time. Next slide, please. So the Cleveland Clinic, as you see in this building, this was the original building in 1921. Those cars give it away. And our mission at that time was to provide better care for the sick, investigation into their problems, and further educate those who serve. Next, should be an overlay. So if you, just keep pushing, next. That's it. So this is the new building that looks like here in London. And for those that don't know where we are, if you visit Buckingham Palace, go to the backyard, you can wave at me right now, and Nick also. And so we're right next to Buckingham Palace, the hospital, although our offices that we saw the first patients were near the Harley Street area. So in 2021, which is this year, we're celebrating our 100th anniversary by seeing our first patient, which we have seen at 24 Portland Place. And for this reason, we have cause for celebration as we expand the Cleveland Clinic, but our values are the same in this city as they are back in North America. Next slide, please. And I think everybody knows the history of innovation of the Cleveland Clinic. This is Dr. Mason Sones, who's a pioneer in angiography. We also have first who did the first total face transplant, and at the bottom left is the first uterus transplant from deceased donor birth in North America that occurred a couple of years ago. So our history of innovation within the Cleveland Clinic concept has been around for 100 years, and hopefully we can show throughout the meeting that we are interested in continuing this legacy. Next slide, please. So the pandemic, how do we prepare for this? Well, as probably people may or may not know, the Department of Defense actually spends more money on research than actually all research done for this. Although the concept of what brought the entire country to the halt was not an external force or anything of that nature. It was in fact this pandemic, which is uncommon, and therefore again leading to the concept that we should probably be redirecting our research dollars to these concepts. Next slide, please. So who will suffer disease and death from this pathogen? And obviously there's a combination of factors which I know you will be discussing over the next 2 days. But it's complex, and we all have to participate and research. An exchange of ideas, which is the purpose of this meeting, is the way that we will be able to contribute, especially to the next pandemic that will certainly occur. Next slide, please. So what is Cleveland Clinic doing? Well, we're a leader in healthcare research and education. We're putting in a lot of money into research, and especially we've redirected a lot of what we're doing in research into this concept of how to battle the next pandemic. Next slide, please. And this is my last slide. So the idea for us is that Cleveland Clinic is a global footprint. The one we just opened in London, and we've been open for about 9 days. But we have Abu Dhabi, which is on the call, as well as Florida and Cleveland. And we see ourselves as a global network with the central figure being in the main campus of the Cleveland Clinic. But as part of our mission, we wish to contribute. And I think this is a way for us to contribute, which is to lead these types of conferences for exchange of ideas. And on that note, I'm going to turn it right back to George or to Nick so they can start the conference. And again, I'd like to thank everyone for participating. So back to you, George.
Thank you very much, Tommaso. And I didn't really think that you would be able to deliver this in time, but you know, you've proven me wrong. Thanks, Nick, for the welcome. So it may seem a very unusual time for organizing a conference such as this, and amidst the building works which are still going on in the hospital, the activation and the opening and everything which comes with that of the hospital. But I guess this institution, Cleveland Clinic, has for a century now built its foundations and its success on research, education, and training. So we thought, what better way is there of showing our intent to continue in that vein here in London, and with the support of all our colleagues from, well, I could say really around the globe, given the slide Tommaso just showed there at the very end. A few housekeeping things before we begin. The entire conference will be live and not pre-recorded, so please do bear with us if there are any minor connectivity issues or delays, but hopefully we can avoid that from happening. There is a chat function which we will be trying to monitor and pose the questions you raise to the faculty members. If you haven't done so, please do try and register also for tomorrow. The whole conference will be recorded and you can access the content at your convenience. So even if you've registered for tomorrow, you don't need to sit through it on a Saturday afternoon, especially if, like today, here in London, the sun is shining, but you can, on an evening, on a quiet moment, go through the sessions which have been recorded. At the end, I have to also say that the syllabus and confidentiality agreement and everything else going with it is available as a handout. And that is where I'm now handing over to Dr. Stephen Gordon from Cleveland Clinic in Ohio, and Savas Vlachos, who's one of my colleagues here in London. Please, Stephen and Savas, over to you.
Well, George, well, thank you. And again, it's just a pleasure to participate in this conference and be a part of this. In our charge, we'll kick off on the science and the practice of pandemics. And I will do so, obviously, with my colleague, Dr. Savas. I do want to get back to Tommaso, a World War I theme. And I want to start with the red poppy, which was memorialized, obviously, in John McCrae's war poem for all the soldiers lost in World War I. To my knowledge, at this time, we don't have such a symbol for the pandemic, despite the fact, obviously, we're approaching globally upwards of 5 million deaths to the pandemic. This includes about 140,000 in the UK, 670,000 here in the States. And I do want to start from all of us acknowledging just a note of sympathy and empathy to those who have lost loved ones during the pandemic. And these numbers are quite astounding and obviously will continue to grow. Next slide, please. But I also want to start by acknowledging the stronger half. And going back about 55 years ago, the Scottish virologist, which is pictured here, June Almadia, was the first one actually to see the iconic spikes of the crown of the coronavirus under the electron microscope. And fast forward today, women have played such a strong role in the pandemic. And I do want to acknowledge, if we look at the husband and wife team, so Dr. Özlem Türeci, the BioNTech, also looking at the NIH vaccine with Dr. Corbett, and of course the Nobel laureate Jennifer Doudna, known as quote unquote the code breaker. So we do want to acknowledge the role, the important role of women in the current battle and in science and in COVID-19. And with that, we have the slide I'll pass to Dr. Vlachos to kind of frame our content.
Thank you, Stephen. And again, a big welcome to all our colleagues and friends who are joining us from around the world. Can I have the next slide, please? The first slide you see there is about the science and practice of pandemics, and so is the whole session. And it's basically about how science has met reality in the last 2 years. Can I have the next slide? Which is probably the previous slide then, the one that was showing just at the end of Stephen's talk. That's it. Thank you. So first of all, the good stuff, I'm not going to analyze the whole slide, but what happened in the last 2 years? Well, we got from a pandemic declaration in March 2020 by the WHO to administering the first vaccines in patients in December 2020, which is just over 9 months. And that's unprecedented. We also got from thinking this was just another type of ARDS to where we are now in terms of treatment choices and drugs, also a significant evolution. Well, that was not random, but it has been the result of a concerted effort by many, many scientists. And obviously you'll be hearing more about that in the event. At the same time, though, we've realized that the epidemiology of this virus is a lot more complicated in the real world than we thought in an SIR model, and that other factors also have a massive impact. And more on that in a little while by James Simon and Tom Fraser. Also, some issues that up until now were mostly academic, such as the ethics of prioritization under scarcity, or the existence of mandates, whether it's masks or vaccines, has become very suddenly very, very relevant. On the world stage, on the other hand, health security, as Dr. Falcone alluded to, has become the new talk of the town. Everything is about security now. And in fact, only a month ago, the agency in the UK dealing with COVID has become the UK Health Security Agency, and that's for a reason. We also saw that health, and specifically public health, has become severely politicized. And all that leaves us in a pretty unsure state about the long-term implications of the pandemic in so many areas of our life. These are very, very quickly the headlines. Many of these issues will be discussed in more detail later on. Again, thanks very much. I hope you enjoy the session. And Stephen, back to you.
Well, thank you, Savas. So it's a pleasure to me to now introduce the next speaker, Tom Fraser, who's my partner and also heads up our healthcare epidemiology program here at the Cleveland Clinic Healthcare Systems. Tom is a very, what I call a very smart thinker, critical thinker, and his charge today will talk about COVID-19, the pandemic, what happened and why. Tom, the floor is all yours.
Thank you, Steve, for the kind words. I'm not quite sure I'll be able to live up to the smart thinker part, but my charge was in 6 minutes or less to tell us what happened and why with the COVID-19 pandemic. Next slide, please. And to put it simply, a virus emerged. And while this may seem surprising, this is from an article by Dr. Fauci and others in the Annals in 2017. And this graphic shows a map that he kept where he started with where did HIV come from, and then over years added all the other infectious diseases that have emerged. And somewhat presciently in the text of this article, they state, because current and as yet unknown infectious diseases will continue to challenge us, these experiences may also serve as lessons that can be applied during the inevitable public health crises to come. And so, the question becomes, did we, as a medical community and as societies, did we fail to see what could befall us and prepare appropriately? Next slide, please. So a virus did emerge, and the initial approach was one of containment, with the goal being to stop ongoing transmission and stop outbreaks. And any containment strategy is based on detecting cases early and isolating them. And in order to do that, you need access to testing. And we're all aware of how constrained testing was when the virus first emerged. And then once you identify those cases, you trace contacts and quarantine, kind of the classic containment approach. Next slide, please. And so here in the United States, when we were first getting started, we had this guidance as to who to test. And again, working under the assumption that containment was possible and that you could identify cases if you had fairly parsimonious use of testing and identifying febrile patients who, at least from the United States perspective, who had a travel history. Next slide, please. But then we started to find leaks in the container. And so this is just a personal experience. A 62-year-old woman, this is in March of 2020, lives down the road about an hour from us here in Cleveland. She rheumatoid arthritis on a biologic, and she had been transferred for a progressive cough illness and non-specific infiltrates by CT scan. And she was hospitalized here on day 12 of illness, and she was in our medical intensive care unit. Next slide, please. And so this led to a big, should we test her? Do we need to test her? And in the United States, we had to call local public health, and our request to test was denied. And of course, I wrote, knowing so much, that there's no known ongoing transmission in Stark County, which is where Canton is identified. And 7 days later, community transmission of SARS-CoV-2 was identified in Stark County. So a very tangible example to me about the limitations of a containment strategy. Next slide, please. And so this virus, this is what we learn over time. And this is a report from the CDC about a visitor who goes to visit family and friends in Chicago, and he shares a meal and goes to a funeral and goes to a birthday party and goes to church. And from this one visitor who was ill but not too ill to travel, we have 16 subsequent cases, 6 hospitalizations, and 3 deaths. And so the virus spreads. Next slide, please. And then we learned that pre-symptomatic transmission is possible, that people can transmit virus before they're ill. And this is from experience with contact tracing in Taiwan, again from earlier last year. And what we learned from these type of evaluations is that the bulk of transmission can occur within 24 hours of symptom onset or shortly around symptom onset. And therefore, containment as a strategy is extremely limited in what it can do. Next slide, please. So then you switch to mitigation. You realize that you cannot control this, and mitigation are interventions to slow disease spread and reduce the peak in healthcare demand, bending the curve. And our tools are quite limited: distance, hand hygiene, universal masking, and now, after actually a very short time, vaccination. And social distancing at a society level is accomplished by limiting population movement, closing schools, canceling events, and the extreme example that we like to throw around, cordon sanitaire, back to the plague. Next slide, please. This is a published experience with both containment and mitigation from Wuhan. This is from JAMA, again from last year. And you can see that they had periods of massive migration as part of the cultural calendar in China. And then they went on lockdown with home quarantine, massive mitigation effects. And you can see the effect of all these different approaches on the estimated reproductive number. And with the combination of all these interventions, they were able to decrease transmission in that province. Next slide, please. So why did this happen? A novel coronavirus with pre-symptomatic transmission, early loss of containment in an interconnected world. And I think we've all learned mitigation efforts are very hard to sustain. The deleterious effects of isolation, the associated economic hardship, and there's politics. And so that's all I have. I'm happy to answer questions when the time comes, but I turn it back to Steve and Dr. Vlachos.
Thank you so much, Tom. And I'm sure there'll be some questions at the end. I now want to turn to my other colleague, Jim Simon. Jim is a nephrologist by training, but has really done a marvelous job in what we call business intelligence, and that's not an oxymoron. But he will help us here, and I think in terms of what we would call forecasting, in terms of the good, the bad, and the ugly. So Jim, the floor is all yours. I think you're still on mute.
Rookie mistake, 19 months into the pandemic. It's been a long journey for us in the analytics side, learning how to work with this pandemic. So if you go to the next slide, we really had to take our data scientists and learn from our viral epidemiologists. And the first time we'd ever heard of a SIR model, which is really a model that models how the virus spreads through society. And it really divides society into 3 buckets: those that are susceptible to infection, those that are actively infected, and those that are recovered. And the idea is that once you have enough people who are recovered, then you get to a threshold which we call herd immunity, which will then extinguish the virus. The problem is this was a purely theoretical and mathematical model. The basis of it was the Spanish flu. And interestingly to note, though, the longest that any of the government mandated lockdowns in the Spanish flu were in the terms of weeks. Just think about that. And we've done this for months on end to years. But it really hadn't been tested. And but we delved into it. People all over the world did, trying to figure out how to model what was coming. The problem with that, if you go to the next slide, is there are a lot of assumptions that need to go into the SIR model. And the first is that the virus will spread uniformly throughout the population you're modeling. If you're modeling a city, that's one thing. If you're modeling a state, we quickly learned that even in the state of Ohio, there are multiple metropolitan areas that are very distant from each other. And then you have a lot of rural area in between. And it's really hard to assume that the virus is going to spread uniformly throughout the state. And the other is that the virus won't spread outside of your modeled population or into the population from the outside. And we know that's not the case. And then finally, once you project a curve, you always have to give the asterisk of assuming everything remains constant. And that's the failure, because trying to predict when the social distancing, when the virus may change how it acts with seasonality or factors we still don't understand, was almost impossible. And we learned that very quickly. The other thing with the model is you have to pick your starting point. So UPenn was really the first place to put out a model publicly, and they were nice enough to give their code and put it out on the web. And they chose caseload as the starting point. The problem with that is when you talk about identifying cases, all cases, you have to assume that you're identifying your cases, that you know what percentage of the total cases in society you're identifying. You have to understand your admission rate if you want to identify model hospitalizations, you have to know your ICU admission rate, your ventilation rate, and death rates. So all of those have to be assumed and guessed basically at the start of the pandemic. When you look at the IHME model, which really became one of the more publicly known models, they started actually at the other end with deaths and then tried to back calculate everything. So they had to assume they knew the death rate from COVID-19 from all infections and the admission rate and the ICU rate and the ventilation rate. And I'll say that even though they're one of the more publicly recognized ones, they're probably some of the least accurate, interestingly. And then from the Cleveland Clinic, what we decided to do is we thought we would start with hospitalizations because it was pretty uniform when someone was sick enough to be hospitalized. At least we thought at the beginning, although that has varied with time. But we had to know the admission rate, the ICU rate, and the ventilation rates. And we didn't even bother trying to understand what the case rates were throughout the country, even the metropolitan area, because our job was really to develop an operational model for hospital leadership to understand what was coming. So if you go to the next slide, we talk about the social distancing, this magic number that we all started talking about. And really the definition not a lot of people understood is the percent of interpersonal interactions that have been eliminated by something. And it was much more complicated than that. The physical barriers, true distancing, vaccinations, innate virus activities, such as effects of seasonality and latitude, which we didn't understand. And it really became this magic number that if you recognize now, we really don't talk about anymore. And the problem is that curves would change on a dime, but we couldn't predict. And we try to go back and retroactively say, well, this is why it changed. So if you go on, the next couple of slides are just illustrations of some of the evolutions of the curves. So this was from the Penn model, and you can see at the bottom, we had estimations of admission rate right at the beginning and social distancing, and they were all guesses. And you can see that the impact of our Cleveland Clinic census ranged from 20,000 down to 3,000, and we're trying to tell hospital leadership what's going to happen. And unfortunately, we had to guess at an admission rate based upon what we thought we could handle. It turned out that that was actually a pretty accurate guess, but you can see here that we were forecasting quite a bit of variety. If you go to the next slide, this is something we termed the hydrograph. And basically we gave options based upon changes in social distancing behavior and behavior of the virus. And we were actually able during the onset of the government actions to forecast when the model would change curves fairly accurately because they were pretty draconian government actions, lockdowns. And you can see the impact of school closures and stay-at-home orders. We were able to show changes in the activity. And that's where it ended, though, because after that, the government mandates really went away, and it was all based on behavior. If you go to the next slide, this is where we developed a machine-fitted learning curve, machine learning fitted curve. And this really forecast the effects of the model based upon the recent activity. It was still a SIR model, and it was very delayed in when it would adjust. So it allowed us to understand where we were going in the short term, but never the long term. And if you go to the next slide, this really demonstrates how our machine learning curves adjusted over time. And one of the things I say is if you're constantly adjusting your models to what's going on, are you ever wrong? And that's where I think a lot of people fall into complacency, thinking that they're accurate because they adjust their model to activity. So they're right for a couple of weeks before things changed. The next slide shows our ability to impact our ability to model the impact of vaccinations on our caregivers. And this was another area we succeeded at because this model was built back at the beginning of January. And you can see the impact in the blue line of vaccinating our caregiver population on our caregiver infection rate. And we were fairly accurate with that in the long term. So that was a success there. And then the last graph I'll show is more recently what we've been able to do is take our recent experience with our surges and understand how the SIR curve should be adapted based upon how the prior surges have developed. And you can see the orange line is the machine learning curve, and the blue line is the activity based on our experience with the September to winter SIR curve. And you can see we're starting to inflect now, and I think it's going to be interesting to see if it follows that blue line. So I'm going to wrap up here, and I know I'm a little over time. If you go to the next slide, that the end result was no major model was correct beyond the short term. None predicted major changes in trajectory at the time they occurred. The experts, quote unquote, advertised that they could predict things, but there were too many assumptions built into the models, and we had an incomplete understanding of the inherent properties of the virus. And as I said, all models update regularly, so are they ever really wrong? Because no one ever held themselves accountable for retrospectively looking back at past projections and saying, yeah, we screwed up there. So if you go to the last slide, UPenn, they were some of the models that were pioneers, and they shared their data, but then they fell into anonymity as more dynamic models came into place. Some models got national media attention without really proven accuracy. And every surge changed course before the SARS curve predicted, and that's an absolute. We've never lived through a SARS curve in Cleveland or in the nation as a whole. Things have always changed beforehand. And the utility of the models ultimately depended on intention in the audience, whether it was to predict what was going to happen or, as we tried to do, describe and inform our leadership of where we were and where we thought we might be going in the short term. And with that, I'll hand it back to you, Steve.
Well, thank you. Just fascinating. Thanks for all the work that you've done. And it's notable now that the Center for Disease Control has now stood up a analytics modeling program at the centers, I think, in part in terms of lessons to be learned. And on that note, we're going now to what I call our Sky team or Fox News panelists here that are going to tell us what we should have done or what we did wrong. And this is an esteemed group. And I think we got one set of slides from Dr. Hamed. So Fadi, please lead us off.
Thank you, and thank you everybody for the invite. I promise you it's not going to be more than 3-4 minutes because I want to have it for the open discussion. For those who don't know me, I'm currently in Cleveland Clinic, Abu Dhabi. I'm the medical director of the medical surgical ICU there, and proud to be here. Next slide, please. So for us, there's always certain facts that we had during the pandemic, and I can tell you we were one of the few countries that started, the exposure with the pandemic early. Actually, our first patient we saw at the Cleveland Clinic Abu Dhabi was almost in March 2020. Although it came in March, but actually we had good time from December to March to really be ready. We had protocols ready, and when I talk about protocols, we really had a good set of robust protocols from ARDS management to Code Blue to RRT to intubation, because we wanted to be ready, because we know that was inevitable to have the pandemic and to have a wave in our institute and the country. We had team assignments really worked well with organizational level to assign team, and actually in early February we had a COVID-19 task force that was led by the CMO in our hospital that looked at the whole COVID itself at the enterprise in order to be ready to look at different aspects, from bed capacities to ventilators to ECMO machines to supply chains to pharmacy medication to staff exposure and all that aspect. So we thought by the first patient we were exposed to and have to in March 2020 we were ready. Next slide, please. Definitely there's always the same challenges, right? Everybody had it, the bed capacities. We had too many uncertainties, right? We did not know, is it like an airborne? Is it like a droplet? What about, the universal process of masking, all those aspects. And just like what James just mentioned at the end of his talk, that peak that we wanted to know, where can we have it? When are we going to have it? Was the $1 million question that we wanted to know it, because we really wanted to try to be ready, because the speculations were between 1,000 to 5,000 ICU bed needs in the community. So that kind of speculation was very important for us. And despite all the models we have, we thought that we may be right, that we will have our peak in May. Next slide, please. So we had the first wave, and actually our first wave was in March. And what really could have done better during the first wave had too many things. Again, I'm just going to through 1 minute go through them. Although we had the treatment modalities, we thought it was too many. And you can see the amount of publication that came out of any single treatment, from antiviral to ivermectin to interleukin-6 to steroids, was overwhelming. We were also the tertiary center of the country, so we were also all the time being asked to refer, accept transfers, and all of that put us at a lot of stress during the first wave. PCR, who should do it? Should we, screen the staff, the patients, the visitors? All of those, really made us in a big dilemma. And then the exposure for the staff itself. I got exposed. Should I quarantine? What's the duration of the quarantine? The CDC guidelines. Then one of the most important challenges we have that what we also could have done better is the OR timing. The pandemic, the peak, we're the center of excellence, and then should we cancel OR? We canceled OR. We were expecting 1,000 admission in April and May, and we cannot just keep the elective OR and in addition to the all admission that could come during the pandemic. Next slide, please. So the beauty that we had almost an 8 months between the first wave and the second wave. And although I think we learned a lot from what we have done wrong in the first wave, the second wave that came to our doors was almost in March 2021. And I think we learned a lot from the first wave. And I think this is what we did better. We knew more about the disease. We treated better and we really debunked a lot of myths. And one, thing that we really may have done a bit, over during the first pandemic is let's focus that who can we help with the COVID. So we went from a massive acceptance to more of a selective process of ECMO referral, advanced ARDS. One thing also we learned from the first wave that we did wrong, maybe we should have really increased in the resources. We know a second wave was coming and we really invested a lot of time in resources pre to the second wave. Psychological support was a mandate. In the first wave, we also were overwhelmed. All the staff were overwhelmed. We know a second wave is coming, and we really focus on the psychological support that we think we have missed in the first wave. And I think with all of that, we really have done a better job, and we had a better outcome when we had the second wave. Thank you.
Well, thank you, Fadi. I think that was just a wonderful overview, and I think we'll kick it back. I see Chris Langrish on the panel. So, Chris, can you give something from the London perspective?
Yeah, sure. Thank you for the opportunity. My name's Chris Langrish. I'm a consultant intensivist at Guy's and St Thomas's Hospital, and I'm the clinical lead for what was the South London Operational Delivery Network for Critical Care, and now it's South East London. And I guess what I wanted to focus on was culture and mindset, going back a couple of years before the pandemic. We know that it's predictable. It was predictable from Tom's talk. And really in the UK, and I'm talking about a large public health system with finite resource, we'd really focused our attentions as clinicians and leaders on efficiency rather than resilience. And perhaps that balance was something that I wish we'd done better in the years leading up for it. In the years leading up to the pandemic, we were very focused on daily flow, operational efficiencies, infection control measures, capacity, in an estate that was potentially limiting. And we didn't really share this with our leaders, our management, and also with our colleagues, our peers, both geographically and nationally. We were very inward focused. And one of the key enablers during the COVID pandemic was the concept of mutual aid. And clinical transfers were really only undertaken for clinical reasons, but we undertook capacity moves aiming to balance needs across the system. We'd sort of developed in the UK quite a heroic and attritional working environment and normalized perhaps a stress, particularly over the winter, where it was usual to cancel emergency work due to elective work due to emergency pressures. So really, had we done enough to share our concerns? Because critical care has evolved over the last 30 years. It's extremely complex and it's difficult to explain to people. And I was struck in the early days of the pandemic. We were pushing at an open door. People really wanted to help, wanted to deploy resource, but they didn't really understand what we needed, and nor could we verbalize it very well. For instance, we didn't have any meaningful system metrics around operational stress, staffing ratios, pressures on the wards. And I think we have to hold ourselves a little bit responsible for that, because it was predictable, and we went into the pandemic with little solution to as a system as to what we needed. There are a couple of examples in London. I think the Nightingale Hospital, which was a large Excel centre, conference centre, which with the government threw enormous resource behind it. But in the end, there was only finite resource. It wasn't a safe environment to look after critically ill people. And I think we could have done more to explain that that wasn't necessarily the solution. So the other thing I'd say is that we made assumptions about the system that we work in. A classic example is oxygen. We didn't, as critical care clinicians, necessarily understand the problems with mass oxygen use and supply, and that led to oxygen failures across our system. Perhaps we underestimated the importance in critical care of the technicians and the equipment we use and its maintenance, and we had really no idea at the beginning what we had. The good news is that all this has changed now, precipitated by COVID, but we have a much more structured, resilient operation in place now, and at any time we can tell where the stress and strains are and try and do something about it. So they're my observations about what I wish we'd done.
Well, that's very, very just interesting to hear, Chris. And I'm wondering if we can now switch to CCF Florida and hear from Dr. Janesh Mehta.
Good morning. Can you hear me?
Yes.
Yes. Hi. So very interesting from all the speakers, and kind of echoes similar sentiments down here. We had, I believe, grossly underestimated upfront how pervasive and how quickly this would spread, and partially at hospital administrative levels and partially at state levels, where of course, Florida being the capital of a lot of people coming in spring break, and there was this massive spring break event in March of last year that was tracked down using cell phone data that took the pandemic back to, I want to say, 30 or 40 states. And that was part of where a lot of preparedness was not present up front. There was a lot of hesitation to masking, a lot of reluctance to testing, just a lot of common themes that have been mentioned that were present over here. The one thing that the state did very well, I thought, was the nursing homes. There's a very, very large elderly population in Florida, and the nursing homes got ahead of the hospitals on this one, and they locked down much before the hospitals. They tested a whole lot more than the hospitals. And if you look at the nursing home numbers for Florida, they were much, much, much better than the rest of the country, and they just got ahead of the hospitals. For once, I would say that the nursing homes did much better than any of the hospitals in the state. But the other problems were similar. We had staffing shortages. Even though we prepared for it, there was a lot of movement between hospitals. There's no central system, so you have a lot of competing private systems that are competing for the same staff and resources. So what could we do better is maybe try to plan a little better, but as all the curves showed, and this is what we were seeing in our curves as well, it was very, very hard to predict when the next surge was coming, and trying to catch up with that was never good enough.
Well, thank you for that, for those comments. I'm not certain. I don't see Joe Zane on, but in lieu of that, I wonder if I can ask a question, and especially from the panel here. And can you discuss the structural tension between what we call clinical experience and common sense versus randomized controlled trials in a pandemic? And I'm looking to my my UK colleagues, because you were able to execute very important trials during a pandemic. So Chris, I'll kick it to you and have the other people comment as well.
Yeah, I mean, I think the clinical trials, particularly for immune modulation and anticoagulation, were very successful in the UK, and that really was based on an established research network and program on a national and regional level that was able to be funded and enact itself fairly quickly, and ask pertinent questions, and we all had input into what questions needed to be answered. In the UK, there's a wide scope of practice. Some tertiary establishments will be braver and use their own clinical judgments and experience, whereas the less well-resourced and smaller hospitals will perhaps wait before randomized clinical trials came up. And it was very clear that some institutions were using, higher dose steroids, were being braver with being brave with anticoagulation, and were indeed using other immune modulators such as IL-6 antagonists way before the evidence emerged, because you are allowed to do that in the UK. But it was also clear that a lot of patients were missing out on this therapy as it emerged that they may have a disease benefit before the trials reported. And that led to potentially inequity in outcomes, which we see in some of the data.
Yes, please, Fadi. Yes.
Yeah, definitely. I would add it's the amount of data flow that came out of this pandemic and just made it was one of the major challenges that we could have done better. You can see every day in the morning you would wake up with like 5-10 new articles coming, and unfortunately those that they were poorly designed made it to the media. I think that was one big challenge for all of us as a physician in order to debunk. And this is, if I put it in my last slide in here, it's still there. Like, unfortunately, by the second wave, we were able still to debunk a lot of myths, but I can tell you, we're still talking about ivermectin despite like a 3 million publications that came out. So that was a very big challenge, is that although we were able to debunk it as much as possible, the challenge with the media was a lot of difficult aspects for us all around the world. The amount of data, the amount of publications was unbelievable. And at the end, when we just went with the basic evidence-based medicine, the basic medicine, the basic critical care we have done, I think that's where we could see the massive outcome and improvement that we have done using the greatest study that came out over the last few months. Thank you.
Sabas, please. I see you want to
Just two very brief comments, one UK specific. So the UK benefited from the existence and of a plan basically on how to do research in the context of an influenza pandemic. And that's what Chris was referring to. There was already some infrastructure in place. It was quickly exploited. On top of that, there was very quick action on behalf of the UK government in that respect in facilitating and easing up a lot of regulation around studies, not just big studies you saw, but also smaller studies that could be conducted in many hospitals. Data protection became slightly less stringent, and that allowed a lot of smaller studies to go ahead. And one comment on what Fadi said about generation of knowledge. I mean, we obviously all witnessed how at some point the generation of knowledge and the speed of that exceeded the speed at which that knowledge could be harnessed and not just translated, but also regulated, which led to this massive variability, which is still ongoing in some extent.
Well, thank you. I wonder if I could pivot to another question, and in this I'll direct to anyone, but I'll look at Tom. So, as we look back in January, I remember when Jim Simon actually activated our command and control, I mean, early on, but we're sitting around, supposedly smart people, but here we are thinking that Wuhan, which is a city of 20 million and a hub, that actually that the virus is not yet in the United States. A little bit of denial. We know that there were obviously issues in terms of testing. There's a nice book called Premonitions out, which is a little bit scathing of the U.S. response. But nonetheless, if I put anyone back now, if you can go back in time, what would you have done differently? And I want to put this in the context of skepticism of science and social media. So even if you were Cassandra, what would you have done, or what would you have done in January, knowing what in 2020, knowing what you know now? Anyone, please.
Well, I'll start. I would say that, for years we've had a construct of how you approach from an infection prevention perspective a contagious respiratory virus in the hospital. Again, based on testing, based on symptom, and I clung to that, because we figured, all right, people are used to this. This will allow people to have some confidence in our approach in the hospital, our healthcare workers. And I basically, I took a week off. Steve was covering for me, and we just kind of ripped the Band-Aid off of just one small thing of, if you have a pending test, you no longer needed to be in isolation if you're asymptomatic. And what that taught me is that I had anchored too much to a non-pandemic approach, trying to incorporate this virus into how we had dealt with, we had dealt with H1N1. We have a lot of contagious respiratory viruses. And so I think that's, again, thinking that maybe you're smarter than the virus can really hold you back.
Thank you. Anyone else, please jump in.
Can I ask a question, maybe addressed to you, Steve, actually, as well as Tom and Jim, in relation to modeling and how it all happened? Isn't one of the big problems with this disease that there's such a difference in terms of individual susceptibility and the acceptance within the population? Take an example: if you had a relative who dies of it, or work in intensive care and see all these dreadful cases of young people dying in front of your eyes or really being affected very, very badly, versus people who are hardly symptomatic. Is there anything in history thinking about, certainly SARS-1 wasn't one of those viruses, because the virulence, I guess, was by and large, and case fatality rate a lot higher in many ways. But is there anything which happened in the past which is similar to this virus?
I'm happy to weigh in. I do want to emphasize, though, that fortunately, this is still an L-shaped mortality curve, meaning that although we've seen child deaths in the United States, I think it's up to 500 this year, by and large, obviously, this is a disease and mortality in people greater than 60. And so that, I think, if I go back to the H1N1 where children were getting sick and you watched moms hold their children waiting to get immunized, that would have created, I think, a big psychological effect if kids, if the mortality rate mimicked the pandemic of 1919. And I'm not diminishing, obviously, the epi in the kids now, but by and large, as everyone knows, it's about 10 times mortality than seasonal flu, but there is that L-shaped epi. But I think there's going to be a lot written. I think the only thing I would state is many of us who traveled to Asia saw masking in the past 10 years, and many of us were maybe shaking our heads. But of course, they learned about SARS-CoV-1, and I do think that will be an enduring non-pharmacologic intervention for respiratory season here in the States. And I'll kick it to others to weigh in.
Yeah, I'm going to agree with you, Steve, that, having worked on our influenza preparedness program, we had already developed a triaging system if people called in with flu-like illness on whether to get them to stay home and not come into a waiting room if they're symptomatic versus if they had high risk factors that are very similar to what we consider high risk factors for SARS-CoV-2, or age and symptom based, whether they come into the hospital. So we had developed at least a triaging algorithm similar to what we ended up using for SARS-CoV-2. And to his point, we've seen in our breakthrough infections that the people that are hospitalized with breakthrough infections are similar to the people who are dying of primary infections. They're older and they have risk factors for it. But the other thing I'd like to comment on is, we didn't have a test for this at the beginning, and it was, at least in America, it was very tightly regulated by the CDC, if we remember. Building testing capacity was a novel, the drive-through testing center, the mass testing center. Trying to even, it took us months to even be able to test everybody that came in the hospital just because of our testing capacity, and learning that it wasn't droplet, that it was airborne. I mean, we go back and our knowledge of this was incomplete to begin with, and I'm not sure we can blame ourselves for a lot of this because, whether you should say we should have been able to develop that testing capacity more quickly if we had been prepared, but there are a lot of things that we weren't prepared for coming into this, and I think we worked as quickly as humanly possible, given the support we were given by the federal government at the time for that.
Tommaso, please, yes.
Just a comment touching on pretty much everyone's reply so far. I think if we were to go back to 2019, knowing what we know now and try to fix something that would prevent as much life loss as possible, I think one of the few things to do would be to try and factor into modeling human nature. Whether that's even possible, I don't know. Behavioral economics are not part of the SIR model. You cannot model how people would cheat on their tests or not obey lockdown rules and all that stuff. Economists are working that out. I don't think their models have been any more successful, but there's many papers trying to combine both epidemiological and economic approach. The other one related to that is the inevitable interplay between epidemiology and politics, because as you saw from the curves Jim showed, and the epidemiology was driving political decision, which in turn were driving epidemiology outcomes. So it was a self-fulfilling cycle where everyone was feeding into it, the subsequent action. And lastly, touching on what George said, and now in view of the wall we have hit in terms of vaccine hesitancy and other things, the messaging. People because of first of all the extent of people involved and in the inevitable spectrum of clinical disease, the messaging was not as clear as it could have been regarding its severity and how it can affect you if pretty much the whole population gets it at some point, which has led to all kinds of weird notions around what COVID is or isn't. So messaging, epidemiology and politics, and better modeling if possible.
Well, Dr. Vlachos, that is wonderful. I know we're up against time, and one thing I've learned in the pandemic is don't keep your boss waiting, and my boss is up next. So in a selfish job preservation mode, I just want to thank everyone for their participation and their thoughts. This has been wonderful, and look forward to working with colleagues across the pond in the future. And thank you so much. Dr. Vlachos, any other comments before we pass this session off?
No, just wanted to say thank you to everyone who's connected and all the speakers who are involved in this. I hope you enjoy the session.
Thank you very much, Stephen and Savas, for chairing this first session and for keeping time. That's really great, and for the intro. So it's a great pleasure now to introduce the next session, which is around pandemic preparedness. And Ray Dwake from Cleveland, Ohio, a very eminent colleague, and my esteemed friend and colleague, Andre Verku from London, will chair this session. Please, Ray and Andre.
Thank you, George. I appreciate the opportunity. Thank you, Steve, for staying on time. I hope we can follow suit in this session. We really have a jam-packed session for here. We have 9 speakers in 45 minutes, so hopefully we'll stay on time. As the rest of the conference, this is a global faculty from Ohio, Florida, London, and Abu Dhabi. So we're looking forward to them sharing their thoughts on pandemic preparedness. So the session will be in 3 parts. Preparedness, increasing the size of the ICU very quickly, and then the green COVID-free hospital, can that be a reality? So for the interest of time, I'm going to give Andre the opportunity to make a few comments, and then I'll recommend that we ask the speakers to introduce themselves as they start, and then go into their talk. So Andre.
Thank you very much, Red, and it's a real pleasure to be here with colleagues from all around the world, as you say. In terms of preparedness, I think it was interesting to hear some of the previous speakers, because I don't think we were adequately prepared or knew what we were truly facing. And I think in terms of what we did, in terms of opening new ICU areas, changing the structures of our hospitals and our working practices, it was an immense challenge that seemed to never go away. It truly was almost a Sisyphean task of working towards something to achieve it, only to have to start the next day as the next wave of patients seemed to come in. I'd be really interested to hear the thoughts of everybody on how they managed to develop pandemic preparedness in their various institutions. And then also what was clear is the fallout from COVID that affected other patients, those who didn't have COVID, and how are we going to manage to keep those pathways that are so important to people with strokes, heart disease, cancer running in the future. And with that, I'm going to hand over to our first speaker, Anchal Kapoor, who's from the Cleveland Clinic, Ohio. Thank you.
Thank you. This is Anchal Kapoor. I have been an intensivist at main campus for 11 years now. And my major role in pandemic preparation was towards education. Next slide. So as COVID-19 started to sweep across the globe, we saw the first case here on January 21st. Between January 21st to March 11th, when the pandemic was declared, next, we felt prepared and we were prepared to tackle this inevitable. Next. So this is the time frame of our preparation at main campus. Next. So direct communication between the ICU ops and incident command at enterprise level, while capitalizing on our well-integrated infrastructure of 10 regional hospitals, we had developed a big surge plan framework around space and expansion, staffing, testing, supplies, resource utilization, and education. Next. Next. Sorry, I had a lot of animations in there. Using the framework from Hicks model, we developed conventional contingency and crisis plan. So below you can see we were ahead of the curve. Next. Our ability to increase the bed capacity by mobilizing resources within our regional health system gave us a leverage of having extra dimension of extension of capacity, which eased us all along in terms of having extra resources at our hands, as well as a strategic thinking to delay the time to crisis. Next, please. So this is how we planned our whole surge planning on space and staffing. Next. Next. So in terms of space, expansion plan was based on our regional hospitals. We had that plan in our hand, did not utilize it fully, but we planned it fully at the upfront. In order to prevent exposure to non-COVID patients and vulnerable population and limit the use of PPE, we started working on cohorting early on. Cohorting in terms of COVID patients and non-COVID patients. In terms of COVID patients, one of our regional hospitals, which had capacity of 28 ICU beds, was converted into COVID hospital. You can imagine an extensive resource mobilization at multiple fronts, including upskilling of providers and education to provide standardization of care was intensely implemented in a very short time period to this hospital. Next. In addition to taking care of very severe COVID patients at Marymount, our healthcare space, which was a newly built building, was converted into an ICU hospital at the same time within a period of less than 1 month to an ICU to take it off to COVID with less acuity patients who required less amount of oxygen, not the ventilators. Next, we worked on 5 hospital plan to take care of COVID patients on the regular nursing floor. In addition to all this, we also planned some cold units with expedited COVID testing as needed in these units for potential organ transplant patients. A perfect example was our medical liver intensive unit, which was turned into a cold unit. Next, please. We worked hard on supplies. In addition to reviewing our current inventory of supplies, technology was used to connect the data assets across the supply chain. It created a dashboard of supply chain, which was visible to us on a daily basis. We utilized community and industry partnership to adjust to anticipated supply shortage. And this is the strategy we used: buy, make, donate, and disinfect. We were ready to disinfect our PPE by the end of March. Next. You will hear more about mechanical ventilation strategy implemented at the main campus, but it started from buying new ventilators, use of non-invasive ventilators, which has capability of invasive ventilation, transfer of equipments between facility, as well as use of anesthesia ventilators. Multiplex ventilation was designed to be there as a last resort. Next. Multiple staffing models in terms of faculties, trainees, nurses, nurse practitioners, RTs, ancillary staff, both in terms of taking care of COVID patient, as well as models for caregivers becoming sick, or backup models were created. Below you can see we deployed education at multiple fronts to prepare people for procedure training in ICU. We educated for redeployment. We'll go on education in the next slide. We were well prepared to actually not take care of patients at the main campus, but we deployed our staff to multiple other locations to help other teams who were feeling stretched out in COVID care. In terms of resource utilization, next, we thought about multiple fronts. The first front was what we can do electively and what we need to stop. This is one example of where we turned down on certain elective procedures, including bronchoscopies. Very early on, we thought about it, and elective procedures were canceled or rescheduled to decrease the exposure as well as decrease the anticipation to ICU transfers. Similarly, virtual visits, the visits which were not needed, either they were rescheduled or remobilized to virtual visits. And we went up on virtual visit as the surge was going up and down. Next, ICU rounds and rounds at multiple fronts were converted into virtual platforms with less number of providers getting exposed to COVID patients. Next, testing. So testing has never gotten this much importance in our history as compared to this current pandemic. A collaboration between university hospitals and Cleveland Clinic developed a drive-through testing facility within a span of such a short time period. Later on, next, a research team developed a prediction model to predict or forecast an individual's patient's likelihood of becoming positive from COVID. So based on that testing prediction, later on, people were looking into decision-making, whether this patient should be tested or not, or what is the predictability of test coming back positive. Next, education played a pivotal role in the surge planning in terms of upskilling, redeployment, and standardization of care. By March 6th, we had the platform ready to disseminate education on COVID internally. Next, we made an app accessible on Cleveland Clinic iPhones for people to learn through these resources, easy access, not going to SharePoint, available on their phones. Next. Next. So we developed educational resources for workforce deployment. Next, both at internal site and external site. We created an internal platform for COVID education. This education was geared towards providers taking care of COVID patients in the ICU, not in the ICU, taking care of patients who are non-COVID. I think I said the COVID and non-COVID in ICU and on the floor, as well as at outpatient front. External site was created based on, we got an educational grant from Pfeiffer and American Lung Association. We created 64 modules for training, 8 modules translated into Spanish, and 100 just-in-time guides for the providers who have never worked on the floors, who got diverted, or who will be deployed to take care of patients on the floor. Next. So this is just to show the request to create an educational platform came through to us in the mid of March, and we were ready to deploy internal platform early April and external platform in early May. Next. So in short, this was a multi-pronged approach. How we were able to accomplish all that by thinking innovatively, anticipate resource needs, creating a quick action plan, identify reliable resources, collaborating with multidisciplinary team, and engaging the right stakeholders at right time, while making sure that we are taking care of each other mentally and physically. We all aligned with our Cleveland Clinic mission, and you will hear from our subsequent team how at each front they'll dive into each front of what I just elaborated in short 5 minutes. Thank you.
Thank you, Anshul. We're going to move ahead with Jamil Debo from Cleveland Clinic Abu Dhabi. Jamil, can you please introduce yourself and go right in? Thank you. You are muted, Jamil. We can't hear you.
Do you hear me now?
Yes, go ahead.
All right. My name is Jamil Debo. I'm the section head of the Neuro ICU at the Cleveland Clinic Abu Dhabi and part of the Critical Care Institute leadership that faced the pandemic and planned for it. And much of the talk, as if me and Anshul coordinated this talk, but we had a similar experience. Next slide. I have no disclosure. And you can move on to the next slide. So in Abu Dhabi, as also Fadi mentioned, please next slide. We had a late surge, and really it hit us in April. And the surge spanned till June, mainly that's talking about the first surge. Next slide. And next. And in Abu Dhabi specifically, the Department of Health kind of structured the way with every COVID positive patient where they will go. Do you have a certain sets of hospital reserved for just observation, and then when they become a bit sicker, to certain hospitals, then moderate sickness, meaning HDU, step-down units or basic ICU needs, they would go to certain hospitals. And then next slide, they will come to us when they're sick, meaning ARDS, proning, ECMO, Center of Excellence for Stroke, and others, they will come to us. So
We lost you again, Jamil. Your voice. We lost
Sorry.
you.
So when we got them at when the patients were really sick, and so next slide. So we got a heads up from the Department of Health that we're going to be getting these patients, and that invitation, it's a calendar event that we wouldn't really forget. Next, and it's as Fadi mentioned. Next slide. You know, this planning for the uncertainty unknown with many of these elements and components that even up to now, there's some question mark. What do we do with testing and masking and how to treat? Next. So really, with all these resources out there for everybody to read, next, we kind of put together this talk. This really applies to the COVID pandemic or any healthcare change, be it if you're setting up a unit program. We need all these elements, as Anshul had mentioned eloquently, interconnected specifically, and not one can function without the other. So I'm going to just highlight very briefly the key elements that we felt lucky to cruise through the first surge successfully. Next. So first of all is staffing. This is a layout, a blueprint of one of the ICUs when we sat down with our architects and people that helped us refurbish our unit to meet the standards, quote unquote, of COVID-19. You can see where the beds are. Next, you can keep clicking for a few clicks to see where the donning and doffing on one side and the other is doffing. We turned the manager's office into doffing areas. Outside, we turned some rooms into physician offices and break rooms to have them work from the outside when take a break, and then go inside where everything should be clean and neat and minimal contamination when they come outside, with appropriate labeling of the units, the lifts dedicated for COVID patients. Next. And then also next, during this surge in terms of space, we expanded next our beds from 72 beds, 3 dedicated units, next into 130 beds. We cohort them between COVID-19 versus non-COVID-19, whereby we added these beds on a regular floor, turning them into low acuity COVID-19 ICU, and a PACU for low acuity non-COVID patients, where we kept going and having to treat the non-COVID sick patients. Next. In terms of staffing, we followed the model of the SCCM, and as everybody know, we were doing much more with the same amount of staff. Next, we created what we consider to be, for us, next slide, a successful model, like recreating DEF CON, if you guys read about what DEF CON is. Next, so essentially, as you see, we create an Excel sheet, a practical model, where you have COVID-19 ICUs and non-COVID ICUs, and on the left side, there's a column where what kind of physicians do we have at hand? We have our ICU team, we added anesthesiologists that have a skill set of procedures, and the deployed intensivists for the surgeons that weren't working or their surgeries were canceled, and others. Next, so we looked at, for example, one ICU, that's the COVID ICU, one of the 2 that was highly sick patients, and we figured that we really need ICU doctors more so than anesthesiologists deployed. Whereas next, in the non-COVID ICU, low acuity ICU, like recovery, one-day surgeries, we figured that this is a familiar zone for the anesthesiologist, and we deployed less of ICU physicians. That way, we were able to kind of manage successfully and safely our patients without with the same amount of staff that we had. Next. And finally, communication, specifically, for example, for staffing was key. This is an example of key communication during this pandemic. To allocate 27 doctors on a day shift and 17 at night and APPs, communication was constant and key. And next, and the final slide here about final 2 slides. You know, as we mentioned, we developed protocols and adapted, as Fadi mentioned, to all the data that's coming out, and then broadcasting it and educating it and turning it into the EMR, and adapting the EMR also when we kept on changing these protocols to the literature coming out. We did create our own internal course for the deployed physician to make them as much possible comfortable when they came to the unit. Next. And our task force next made sure that everything was communicated to the hospital. We were aligned with the numbers internationally in CCAD next, and most importantly, made us prepared for our internal supplies and facility, and made sure that all of us are stewards for our own resources and supplies in the organization. Next. Next. And this is where we had the next, our visibility on the supplies. Next. And finally is a thank you for everyone involved, all the heroes that are listening to us. One of my favorite signs, as you see here, is that this is the donning area. So this was placed strategically where when the caregiver was just donned in and ready to go into the ICU, they looked down and they were reminded they were heroes. And to all our Cleveland Clinic folks, as you probably, many of you know, we had help and support from Ohio and Florida that came and supported us to get over the first surge successfully. And so thank you.
Thank you, Jamil. Our next speaker is Chris Langrish. Chris, are you on? Yeah, here, I see you, Chris. Go ahead. Take it away. Introduce yourself. Go ahead.
Next slide, please. Yeah, so I deliberately chose this this picture. This is St Thomas's Hospital by the London Eye. No, back one, please. And it shows the clouds gathering, because what we did in London didn't emerge quickly. It was we could see what was going to happen, and our system was under a lot of stress before the pandemic. So this this picture represents how it felt last March. Next slide, please. Next slide. Thank you. So we are divided into operational networks, as I say, but networks, we're seeking a role in the NHS. There is a structure. We would go around our business, organising conferences, organising web-based app sharing clinical guidelines. We'd look at each other's outcomes, and we'd work on innovations such as intensive care transfer services. And we were gaining momentum, but we had little operational input into each individual institution. And you'll see in the middle, and I've put it smaller, you probably can't read it, is the 2013 plans for pandemic based on flu in the UK for the whole NHS. That's in 2013, and the circulation list doesn't include local clinical operators. Next slide. So the NHS, as you know, is highly centralized, politicized. During the early days of the COVID pandemic, we had people on the streets clapping us, all very emotive, and that's balanced against strict local trust, institutional governance, which is important, competitive markets for performance. We have an established inequalities in resource. In our network, we have 2 large fully functioning tertiary centres and a number of small 10-bedded units, and there's a variability in clinical outcomes. As I alluded to earlier, we don't have penetrative data and metrics as to our operational stretch and strains, and the IT is relatively weak. Our baseline is of high occupancy, staffing, vacancies, and an ageing estate. And another important factor is elective and emergency work is operationally intertwined. So it's the sum of, if one goes up, the other one goes down. We had limited awareness of our equipment stock, and we weren't in the habit of moving critically ill patients around apart from clinical reasons. We do have an independent sector in the UK, but their role in all of this is unclear and ill-defined. Next slide. So almost immediately there was a governance structure put in, and I'm not going to go through this, but it shows that there is a hierarchy and there's central command and peripheral command. And the role of a local network such as us was to supply information, informatics, and to inform. And then that would go up the ladder in a rather unwieldy way, and you might get a decision back within the next 72 hours, which doesn't help you when things are escalating in front of your eyes. Next slide. However, the structure is well thought out. It recognises the MDT basis of critical care and the clinical operations. It recognises research, the importance of infection control, education and training, rather like the other speakers, and it recognises the MDT inputs that are required in the complex model of critical care, including pharmacists, drug supplies, technicians, and of course nursing leaderships, which in the UK we're very short of nurses, and that skill set is clearly the most valued around at the moment. Next slide. So over the time, a drumbeat emerged that would enable us to inform nationally and regionally into the national structure and enable key decision making and funding and resourcing in an equitable way. And this was our life and still is our life every day. Local operational pressures are centralized and decisions are formalized and sent down the ladder. Next slide. And of course, it's all based on local information. You can't do anything without measuring the thermometer, using a thermometer and measuring the stresses and strains every day. And we use WhatsApp for this. So every day at 7:30, still to this day, all our units will come in, and you'll see some of the markers, what they're informing us of. It's staffing ratios, particular stress, ECMO numbers, the number of patients, and then we generate a spreadsheet which is shared, and each operational pressure is escalated within the organizations and within the NHS. So everyone can see where we're at. It's sharing the mental model. Next slide. So one of the great successes was the introduction of a critical care transfer service, which enabled us to equalize pressures and patients across the sectors and provide aid to other regions within the UK. There are lots of patient transfer. We started our own local service. It's now performed over 2,000 critical care transfers, which is an awful lot, safely. And this was the tool that enabled us to equalize pressures a lot across the start as units struggled to improve their increase their capacity due to limitations in staff and equipment, but they got there in the end. Next slide. Of course, all of this needs reflection, and one of the role of a critical care network would be to review, discuss, and transparently look at outcomes and perceived weaknesses within the system. And we managed to do that across our network. And we have a great case mix program called ICNARC in the UK, which I'm sure most of you are familiar with, which measures outcomes and compares it against a case mix. We use this to formulate discussions, and over time, institutions are more happy to share their outcomes, share their lengths of stays, and enable us to really transparently see where resourcing is required, because the future will be in the UK around integrated care systems and achieving population-based improvements, and that includes critical care. That's me.
Thank you. Andre, do you want to introduce the next session and speakers?
Yeah, so our next session is effectively how do we manage this massive surge in patients and building up our intensive care capacity rapidly, tripling the size of your intensive cares in a week. I'm really looking forward to hearing how other people do it. I know the challenges that we had with it. The first speaker is Eduardo Mireles from Ohio, and take it away, Eduardo.
Thank you very much, Andre and the organizers. I'm Eduardo Mireles. I'm the director of the medical ICU here at the Cleveland Clinic. Next slide, please. The summary of what we did is using the power of many. We were several centers in Northeast Ohio, all marked by a blue star here. And early on, when we started the planning, the exercises, it was clear to us that it could not be just one and everybody fend for themselves. We had to unite to be able to distribute the load of patients that was in our mind gonna come. We didn't know how big, where it was gonna come from, and how intense. So there was a lot of conversations here. Next, please. This is a cartoon that highlights the bed availability of these of all of us together. We'll start on the top row. That's what main campus has, and you'll see on the first box is the medical ICU, which was our main footprint for the patients with COVID. We have 64 beds, and those 64 beds are always used. We work at 90 and above % capacity all the time, And but there's also the CQ, the neuro ICU, the CICU, and CVICU. So we have a large footprint, as I will show you in a second, within the main campus. But when you add all of our other hospitals in the region, South Point, Fairview, Akron General, Hillcrest, Marymount, and many more, that added a number of beds that could be used. And early on, we started saying, well, how many patients do we have? And you can see them marked by the blue little men that were patients that were on mechanical ventilation or on non-invasive ventilation, POIs, patients of interest, and or under investigation. And so that helped us have a better idea of where we were placing the patients. Next slide, please. This is a more local level point of view. This is at our only ICU within the main campus, just our NICU. And here is a debriefed environment of how did we adjust. We created phases similar to many of all your centers. And in phase one, it was extended to our capacity within our usual practice, meaning within all the beds, we still have to take care of patients with other conditions. I mean, we were always full, and now we have full plus COVID. And so we created a geographic area where we were able to care up to 43 COVID patients at the same time with full support of whatever was needed, plus increase the number of boarders, patients outside. We usually have 64 patients, but actually our census is 73. So we're used to take patients outside of the unit. And that, as well, we used other teams within our team, which one is the MICU transitions teams, also called MTT, that helps us move patients in and out of the unit, as well as the TIL team, which takes care only of boarders. And we extended the functions of those teams. One of the key items that we had was how to cover the nights. And the day we have a lot of people, but covering nights becomes a real challenge. So increasing the amount of our trainees, helping our staff was essential. And we put triggers, specific triggers at which we will start increasing level of phase according to where we were. I will point out to phase two, and this is a clap out to all the other units and teams that were involved on this, is when we could not handle with our usual teams, we went on to start having MICU boarders cared by other teams. So we transferred care to the CICU, the neuro ICU, the CVICU to help us care for those patients. And we offered support from our, what we called our resource team, to help them care for those patients, because evidently, even though they are all intensivists, these are patients that are cared usually by a team in medicine. And so you're not used to some of the conditions that we were dealing with. And finally, there's phase three, in which we started covering areas that were not usually used for critical care. And in those circumstances, we created a diet team, which I will show you in a second. I will highlight that we did have to open another area in the hospital, which is called G91 under emergency situations, which is a low-level ICU in a regular nursing floor to be able to care for those patients. The area is set up to care for critical care patients, but it was a new area for all of us. Next slide, please. This is that. So that was our local level. I want to show you a little bit of the overall level of how much we could expand if needed to. So at level one, within our enterprise here in Northeast Ohio, we were able to cover 348 beds, and that's only with the MICU or the Respiratory Institute support, with extra help from the internal medicine residency. And they are also, I know that everybody has pushed, but our residents, I mean, they live under a different environment, and without them, we would not have been able to care for many of these patients. When we went to level two, it was, as I told you, the Anaesthesia Institute also helped us care for patients under these circumstances. And we could go up all the way to 520 beds across the enterprise. And then when the sky was falling, which we never got there, was when we would be using the ICUs, PACUs, endo suites. I mean, there was a whole map of all the areas that we could use. And technically, the Northeast Ohio bed capacity for intensive care was all the way to 1,000 beds, if you see there, which sounds wonderful, but you know, you need people to handle that. It's not just the ventilators, it's not just the ability of a bed, it's the teams that take care of it. And now more than ever, that's more relevant than before. Next slide, please. So here, Maria, if you can just click all the way to the end. Sorry for the animation, but this was the diets. Essentially, what we created. The whole thing screen will fill up with stuff. And here, what we wanted, if there was a search, was to use an intensivist or plus minus intensivist, one of our fellows. Keep going on the slide, Maria. Thank you. We had them supervising 3 teams of patients that would have, or 3 teams that were made by a diet, which was a non-ICU attending physician with an APP, advanced practice provider, and a trainee. And with that, we were able to cover up to 30 patients. Next slide, please. And what that did is it expanded our capacity. Keep clicking, Maria, all the way to the next slide. Thank you. That helped us cover a large amount of patients. We did not activate that, but we did try it in one of our units to be sure that it worked, because everybody writes about it, but if you don't do it, you don't know how it's going to be. And that was the brainchild of our team. Ren Ashton ran that team for a week, and it really taught us some of the pain points that we would do. I would highlight that we also created this grid that helped us what we call conventional phase 1, extension phase 2, and contingency and crisis, of how we would expand our care and how we would be covering these teams according to where we were, all the way to 947 beds. Next slide, please. So we created all these resources. I put them there because I do think that all the work should be shared. And this is work that Anshul Kapoor talked a little bit at the beginning. It has a lot of, actually, I like to see this because it evolved on our knowledge of how to care for these patients. I would also put here a point on one of the key items, Andre, that really challenged us and is challenging us right now, which is staffing. Our nurses are going through a migration, at least in the United States, due to economic pressures, and they're moving from one place to the other. There's a lot of staff tension going on right now because of the burnout of having to deal this and being faced with it. And so are we able to have space for the patients? Absolutely. Our staffing is the key part, and they are the most precious resource, and we have to really focus on them and their health. With that, I will end. Thank you for the opportunity.
And our next speaker will be Janesh Mehta, so we'll be hearing the Florida experience of managing the same pressures.
Yes, thank you. Hi, I'm Janesh Mehta. I'm the Director of ICU Operations at Florida, which is based close to Fort Lauderdale in Weston. We're a relatively small hospital. Can we go to the next slide, please? So what we experienced here was quite different from what Eduardo just described in Cleveland. We have a very large metropolitan area, very densely populated metropolitan area, but our hospital is relatively small. It's just a 200-bed hospital, and it's an aberrancy in that it's a high acuity transplant center with about 25% of our beds being ICU beds that typically run 95 to 100% occupancy at all times pre-COVID. We also have a very, very high turnover of our census every day. So the hospital typically discharges close to 30% of its entire census on a daily basis. So we have throughput issues, challenges on a daily basis, even before COVID was on the horizon. So there are very, very few redundancies in beds, staffing, supplies to account for expansion plans and provisions. So next slide, please. With that being said, when we started to prepare for this, the hospital administration came to us and said, we need to increase our ICU capacity. There were, of course, a lot of challenges and opportunities as well. We are part of 4 or 5 large competing systems in this area in South Florida, and the resources for staff especially are shared, and it becomes a supply-demand issue more so now than it has been in the past because of the scarcity and the migration of staff that Eduardo alluded to. So yes, you can have the planning to have the staffing in place, but you may not have the staff pool to recruit or hire from. We also have a very large geriatric population, so our waves did get younger as we moved along the pandemic, but younger is relative, and even our younger waves were in their 60s, and our first waves were more in their 70s. So it makes it a challenge. It's also a potpourri of different cultures. It's a mix of a lot of different beliefs, and you have certain populations that are more accepting of end of life, and there are certain populations who are not as accepting of end of life, and it just made it a challenge to plan for the surges and how many beds would we need for the ICU. So that was our background, which was slightly different in Florida compared to Northeast Ohio at that time. Next slide, please. It did help, I must say, tremendously to be part of the Cleveland Clinic at that point, because there were a lot of shared resources, a lot of shared experiences that helped in the beginning during February, March, April planning of the pandemic. There were all of those prediction modeling curves that we were able to dig into, a lot of the educational resources that were placed on the common drive, the shared drive, the apps that Anshul mentioned. So it was very good in that sense that yes, we are a small little hospital in Florida, but we have a huge network of support in Northeast Ohio that we can always fall back into. So that part was very good for us. This was a summary of what we did with our bed capacities, and we never had to go to phase 4 and phase 5, but we did end up going all the way up to phase 3. So at our baseline phase, we have 48 beds, and we can dig into 22 beds in the PACU area, which we did have to use for our non-COVID ICU. So we had to create space for post-transplant patients, post-surgical patients, non-COVID ICU patients, and we separated the ICUs from the non-COVID ICUs by using the PACU as our clean space and using the ICUs as our COVID space. At the height of all of this, we could have gone all the way up to 130 beds, but luckily the most we've had to use so far has been 52 beds. So we were able to plan for the surge, but luckily did not need to use all of that surge capacity. Next slide. The supplies were never an issue, again, because of the varying levels of surges between different states. We were able to utilize a lot of supplies that could be shipped back and forth from Ohio. We used a lot of ventilators, personal equipment, a lot of stuff that we could go back and forth because fortunately our surges did not align at the same time. So they were always lagged by a month or two, so we could share some supply and resources. The first surge, which was not our worst one, last March and April, was the one where we did run short on PPE, but we were able to reuse and sterilize some of the PPE resources. So never absolutely had to go into work without PPE, just had to reuse and sterilize some PPE supplies. This last surge was our biggest one, July, August, September of this year, and that's when we had our biggest crunch with oxygen. There was a time when one of our hospitals here was down to, I believe, 7 hours of oxygen supplies with a truck about 2 hours away to deliver oxygen. So that was one of our worst crises. Was we were almost out of oxygen at one of the hospitals. But apart from that, supply chain issues were not that big of a problem. And again, we learned a lot on trying to control factors in the supply chain that were within planning and preparation, and factors that were not. For example, the oxygen supply chain is not completely within our control, and it is a private industry, and it does rely a lot on their availability of drivers, their drivers not calling out because of COVID, the trucks not breaking down, and all of that part. So it was interesting. It was fun to plan for all of these things, and a lot of lessons learned during all of these surges. Next slide, please. This was the biggest challenge for us, was the staffing. So the caregiver staffing was not that big of a problem. We created similar models to what Eduardo alluded to, the dyad model that we would have to fall back onto if we had gone to our phase 4 and phase 5, but we didn't have to go there. We were able to manage our staffing with our current staffing model with the addition of house staff and APPs. So we were able to offload some of the non-COVID cases to our anesthesia teams, and we were able to increase some of our residents and APP providers to increase our capacities on the conventional ICU teams. So we did have plans for the dyads, but we did not have to go on to those teams. And yes, we did implement it for a week or two in March just to make sure it works. And yes, it does work, but it's not quite the same as having a dedicated MICU team with MICU staff. The educational resources we fell back upon Cleveland that were already discussed previously, and very, very useful to be able to educate the entire hospital staff to be able to manage COVID patients should the need arise. Again, apart from 2 weeks in March when we had to do the training just to see that we had the capacity, almost all of our COVID patients were managed by the Respiratory Institute and help from internal medicine. So did not have to fall back upon any of the other departments for help for COVID patients. And that's all that I have. Thank you.
Finally, we'll be hearing from Dominic Spray from St. George's Hospital in London.
Hi, everybody. Thanks, Andre. By way of introduction, I'm the clinical director for an NHS teaching hospital in London. We had a baseline of 60 ICU beds. I'm also Chris Languish's equivalent as the clinical lead for the South West London Critical Care Network. What follows is a bit of a personal skim over some of the broad issues related to a rapid ICU expansion within the NHS framework, which is slightly different from what we've heard from across the pond. The first thing, I guess, is to echo what many speakers have said already. The first question you must ask when thinking about increasing the size of your ICU is what are you actually planning for? How big do you need to go, for how long? What sort of lead time do you have? We've heard from Jim how difficult it is to provide accurate modelling, but even a ballpark figure goes a long way to affect what models you choose to stretch your staff, at what stage you're going to stretch them, and where, more importantly, in the NHS, are you going to expand? Next slide, please. This also affects what other services will be compromised, certainly within the NHS. ICUs don't exist in isolation. We are all part of a hospital or all part of a network with other ICUs and other hospitals. Next slide, please. We found we needed to spend an awful lot of time and energy talking with our partners, both within the hospital, within the network, and the wider medical teams about how to collaborate and use the wider capacity that the network and London offered, and what services within the network and within the hospital we are going to have to compromise at what stage of our expansion. At that point, I think you have to especially bear in mind the stress that will be placed on some of the other services within the hospital. So acute medicine for a start, perhaps we underestimated, certainly in the first wave, how much they would be stretched and how much pressure they would be under. And the concentration was perhaps a little bit too much on ITU. And also a note at this stage that if the estates team and the medical engineering team are not your best friends already, they really need to be. Next slide, please. And that's because, as Chris Languish has already said, in the NHS, we are working with finite resources. We have no more resources on tap. With a couple of notable exceptions in London, no NHS trusts have unused space within their hospitals, nor staff, nor kit. We have no built-in redundancy. We are operating at pretty much full capacity all the time. Therefore, it becomes even more key to plan which services will be asked to support your ICU at which stage of expansion, and try to put fairly robust triggers in place for these to happen. So, for example, when will you stop priority 3 elective surgical theatres and release those staff, that kit, and that ward space to support your ICU expansion? Next slide, please. Pragmatically, the hardest part of any short notice expansion that we've seen is the acceptance that quality will suffer. We can't maintain our usual standards when we are stretching our services, and that causes emotional trauma to the staff. The best way I heard of to rationalise this is that although the care was below our usual standard, the alternative for these patients was to receive no care at all, so they were better off with what we could offer them with our stretched staff. Getting staff to accept this is really hard, but it's quite important if we're going to protect our staff that they realise this, and that they don't go home thinking they've done a bad job at the end of the day. They go home thinking they've done the best job they possibly can in the circumstances that they find themselves in. Next slide, please. In terms of space, there really are only a couple of options. You either expand into non-ITU wards, which firstly requires displacement of that service, as we've talked about, and effectively rations care to COVID patients at the expense of those patients whose service you're displacing. Plus, of course, the estate you're moving into may be a bit risky in terms of the layout, requiring a higher staffing ratio, the gas supplies, the electrical resilience of ventilation, for example. So there is increased risk of going into that estate. The alternative is you try and put more beds into your existing ICU space by double pendenting, for example. Now that can increase the risk of nosocomial infection, but at least you are in familiar territory in a ward, and it helps with staffing resources. In practice, depending on the size of our expansion, we ended up using both models, of course. Next slide, please. As everyone has alluded to, the biggest challenge in all this is staffing, without a shadow of a doubt. We've used the pod and team models that the other speakers have described, and found it really most useful to distill down to what the actual core skills of each group of staff really are, the things that only they can do, and concentrate on keeping them doing those things, whilst other people can pick up the peripheral aspects of the job, perhaps the lower value tasks. So we wanted our consultant intensivists to concentrate on the overall strategic management plans for the patient. So there was a coherent management plan going forward that wasn't getting changed every day as different clinicians came in, and keep them fresh for that. Other people can do the lines, the tracheostomies, that sort of thing. Nurses need to spend time with their patients. They don't need to spend time drawing up drugs, for example, so that task could be reallocated. And as a couple of speakers have alluded to, please don't forget the non-clinicians in all this. The increased patients need a huge amount of increased backroom staff, for want of a better term, especially to collect the reams and reams of data that are requested on a seemingly hourly basis. And of course, if all else fails, you can always get the army in. Next slide, please. Thinking about kit, we had to be a bit inventive. The medical engineering team are our best friends now. This was us using baby monitors when we used a 4-bedded theatre suite, or a four theatre suite to put some COVID beds in, and mounting an ad hoc central monitoring station. We wrote alternative drug regimes, such as enteral sedation for when we ran out of drugs, or syringe driver shortages. So you need to be a little bit inventive around the kit you've got. But the first chance you get some decent kit in, because as we found out, to our cost, anaesthetic machines aren't particularly good as long-term ventilators. Next slide, please. Looking at the opportunities that have come out of this, I've only listed a few of the very many that have come out. Perhaps the most important one for us that Chris alluded to earlier is the spotlight that this has shone on the relative lack of ITU provision in the UK. And we have political awareness of that now, and perhaps a lever to address that balance. Next slide, please. So I think that's my 5 minutes up. Thank you for listening. Finally, just remember, when the stress is getting too much for you all, that one day, hopefully not too far away, all this will be over. Thanks very much.
Thank you, Chris, for the sticking to the time limit, and for the beautiful, beautiful pictures. I always say pictures, you can say whatever you want when you use pictures instead of words. So thank you for doing that. Let's move on to the next session. Let's talk about the green COVID-free hospital. Is it a reality? Can it be done? And our first speaker is Dr. Cooley. Hassan.
Thank you, Ray. And thank you, Andre. Thank you, George, and the organizers to participate in this wonderful conference, really to meet many of our colleagues, new colleagues as well, and Maria and Lauren for organizing this. I'm going to try to be short and save some time. I know we're constrained for some time there. Anshul and Eduardo and Janesh shared a few things there too. So next slide, please. So to set the stage for this, really, I mean, you have heard quite a bit about how we manage the COVID, the non-COVID patients, but one important part is the structure, the teams that you have. When you heard about when you are in Northeast Ohio in terms of the type of ICU beds we have, you start off with a baseline of 500 plus ICU beds, and we're able to to scale up quickly if needed to 1,000 plus ICU beds. That's going to provide us with some opportunities, with some options to do that may not be available in some other health system there. And then, the same thing, you can even add another 1,000 hospital beds with the Hope Hospital in the health education campus there. So that's the background to how we did some of these approach to a green hospital. Next slide, please. So early planning, as you heard from everybody, is important, and seeing the foresight of where we're going and what we need to do, and leverage the resources that we have. When you talk about a green hospital, the flip side of that is actually to be able to manage and cohort some of the COVID patients in either one hospital in some areas. So you free up some beds and space for non-COVID, and that's what we did there. We stood up one of the hospitals as a COVID hospital and managed patients across two, based on planning and back and forth and brainstorming around it. Understanding that we absolutely need to be dynamic in that, because what we saw as time went on, you cannot really afford to do that often and continue to have certain hospitals that are COVID-free hospitals. Next slide, please. So what are some of the advantages of having a COVID green hospital? And I think, you have heard from many of our speakers there, to create that geographic, either unit-based or a hospital-based, all patients are COVID negative, minimize that social exposure, the safety of undergoing organ transplant, protecting some of the immunocompromised patients. But to do it effectively, you need testing. And you did hear from Jim Simon and others, how limited our testing capacity was early on, but opened up and kind of really facilitated us being able to do this there. We transferred several patients between different hospitals when they were tested in the ED, tested negative or tested positive, depending on which ED they're showing up to, and if it's a COVID cold or a COVID, positive hospital there. Next slide, please. So our approach initially was to create that 5-hub strategy, and one of them was a fully COVID hospital that you heard, and that created capacity for us to create actually these green COVID hospitals overall, and green COVID also some ICUs that were able to staff there, and then allowed us certainly to, as time went on, to preserve some of the surgical capability and capacity, which is one main reason to be able really to serve. We're here not just to serve COVID patients, but to serve everybody, even when things seems to have really stalled or stopped, which is not the case there, and continue to reassess and make changes and adjustment. Next slide, please. We, doing that using some levers and occupancy and capacity levers that allowed us and facilitated what we need to do. So we pivot from moving patients from hospitals to the other and have a visual management team and system that I showed you earlier on too, where we huddle every day and we look at where we have, and we manage patients literally on that moment too, and then continue that conversation going to move COVID patients to a COVID hospitals and non-COVID patients to other hospitals too, to continue to function and support the full team and then the mission for the Cleveland Clinic too. Next slide, please. And this is an example actually from London. Early on in the pandemic, that was published about a resuming elective surgery in a prospective cohort study that was done during the pandemic. And what they were able to do through testing, through other resources, is to prove that over 300 patients elective actually fit more onto what we call a non-essential surgeries here at Maine in Ohio too, and be able to facilitate doing that safely. Looked at outcomes like mortality, like testing positive, and proven that this strategy, by testing and designating a hospital, you'll be able to continue to serve the other non-COVID patients, which is essential, as we have seen often that they were delaying care. That was realized there too. Next slide, please. So what are the lessons that we have learned? Systemness is very important, and to be able to leverage what you have, even if you don't have it within your health system. Our health system actually also reached out and led and was able to look at the regions and facilitate collaboration and coordination there too. You cannot communicate enough when you want to really do that, and really the message and why we're doing this too. The teamwork and the collaborations within the specific department, specific institute, and across the region is very important, and how it, that power of what we call a one team, and I think we realized that and appreciated that quite a bit during the pandemic, and we continue to to do that as well. So with that, I'll end and hopefully spare a few minutes for my colleagues coming on, and I'm happy to take any questions too. Thank you.
Thank you, Hassan. Can you move on to the next Fadi is our next speaker from Abu Dhabi. Go ahead, Fadi, introduce yourself. And I know you did that the last session, but you can go ahead.
Thank you again, and I'll be again on time with no more than 4 minutes as promised. So my name is Fadi Hamid. I'm a medical intensivist and pulmonologist at Cleveland Clinic Abu Dhabi, currently the medical director of the Medical and Surgical Critical Care Unit. Next slide, please. So again, as everybody alluded earlier, there were too many challenges during the pandemic, and that concept of a COVID-free or a green hospital really had a lot of challenges. And we're talking about a single hospital, not just like we don't have the luxury of Cleveland Clinic main campus where there's many satellite hospitals that they can break down the services. We have to function through our own, campus. So talking about Cleveland Clinic Abu Dhabi itself, we're a center of excellence needed, that provide service through all the nation and the country, and that service had to continue during the pandemic. We also had almost 30% increase in the volume of transfer requests for non-COVID patients. We had already many scheduled advanced surgeries from neurocardiac, advanced Whipple's, hepatectomies that had to go during the pandemic. And then the usual call at 3 in the morning that despite the pandemic, we have a donor, we have to do a multi-solid organ transplant within the next 24 hours. So all those challenges were happening with non-COVID patients during the pandemic itself. Next slide, please. Now, at the same time, can we ignore the COVID? Because we know COVID does not only come as ARDS or pneumonia. We have the COVID stroke patient that we're the only stroke center in the Abu Dhabi. We have to do the TPAs, the thrombectomy. We had the cardiac COVID patients who need the acute STEMI, who needed to get the cabbage. We have our solid organ transplant patients who also had COVID. At the same time, we have been receiving almost the famous calls every now and then from nearby hospitals that we have COVID patients, we need your help, we need ECMO, we need proning, we don't have ventilators. So yes, we try to be as much as possible as COVID-free hospital, but you can see the challenges that happened during the pandemic with one single hospital with one campus. Next slide, please. Next slide, please. So simple action, let's work together, divide the work. We did simply what Jimmy mentioned earlier. We have the COVID units with the Center of Excellence, but at the same time, we did expand the non-COVID ICU. So we have our normal ICU capacity with COVID. We did the other non-COVID units where we had to expand our capacity. But at the same time, like everybody also mentioned, we need more staff. We need to have more capability to staff those units. We can have as many beds as we can, but can we staff the beds? Next, please. So deployment, as everybody mentioned, we did increase actually our capacity to another 50%, going from 70 to almost 120, 130. And we just made the hospital a green hospital with the non-COVID and the red zone with the COVID bed. We deployed the physicians, and by that strategy, we were really able to do the no patient left alone act. We were able to continue our 100% non-COVID capacity functionality with maintaining all the needed action for non-COVID patient, plus provide the high acuity level for all the COVID patients we needed in our ICU and in our hospital. Next slide, please. So in summary, I think it's never completely green, but we can definitely divide the pitch. 100% green hospital in my mind does not exist, but green teams really do present. Patients first and no patient left alone act worked appropriately when we had the appropriate staffing model, and it's still in my mind we're definitely stronger than a pandemic when we're prepared. Thank you.
Thank you, Fadi. Great advice. And Georg, next slide. So our fearless leader is our last presenter in this session. So Georg, it's all yours. Thank you.
Right, I don't know. I've got minus 13 minutes left now. Can we go to the next slide, please? And the next one. I think we've heard this already, that the UK is not blessed and England with bed capacity. Just as an example here, if you take my native Austria at the top, per capita has got probably about 3.5 to 4 times as many ICU beds as England has got. We managed to increase bed capacity quite significantly during the second wave, but at, as you can see, and that is our normal bed occupancy of around 90 to 100%, even during summertime now. In Austria, from my knowledge, when they hit 70% bed occupancy on ICU, there were considerations given to immediate lockdowns, and that's still the case right at the moment. Next slide, please. So can a green COVID-free hospital ever work? Well, during the first wave, it was actually not necessary. Nobody got into hospital. Everybody was at home in lockdown, and even emergencies didn't usually make it into the hospital. If we think about the green COVID-free pathway, it clearly, from a UK perspective at least, would need to be elective, a clear pathway. Could be done with potentially high volume, very low risk surgery, anything that does not have any interdependency. Obviously, you would need adequate diagnostic and consultation support, but as I said, if you had complex surgery, that would be very difficult to accomplish. Excellent community in terms of viral and microbiological testing prior of patients coming into the hospital, and then you could potentially decompress the acute hospitals. Challenges, clearly, as we have seen during all waves, would be cross-infection risks due to staff or visitors, and problems with testing, especially if patients or visitors were to self-test. Next slide, please. Would a green COVID-free pathway work in a large multi-specialty hospital? And that's really the reality nowadays in the UK, and certainly during parts of the second wave, but also the third wave. In other words, an emergency high-risk pathway next to an elective or tertiary pathway, and trying to physically separate that in the same hospital in the UK is near impossible due to the state of the capital estate. Again, one of the prerequisites really would be fastidious and very accurate viral and microbiological testing before patients come into hospital, and regular screening during the hospital stay with very, very fast turnaround times. And then obviously effective infection control measures, which again, often due to infrastructure problems, is very difficult to accomplish at times. And even then, we've got problems in as much as there are shared diagnostic facilities, and it's often very difficult to physically separate pathway patients. And the high bed occupancy rates combined with failed discharges and admission blocks make this even more difficult. Can I have the next one? Could it work? Well, the hospital I work in the NHS at least, and for a little while to come, is a very large specialist tertiary referral center, and at the same time an emergency and community hospital. So as you can see here, there is a lot of tertiary stuff going on. It's the largest transplant center in Europe, super regional bone marrow transplant unit, and so on, one of 4 major trauma centers. And you see here at the bottom in the table the patient numbers, COVID patient numbers during first, second, and third wave. These are not ICU numbers, but hospital numbers. In the third row, you've got the critical care numbers displayed. And I think what is interesting is the penultimate row, which shows you the non-COVID ICU patients, which pretty much were non-existent during the first wave. But by now, and I appreciate it's very small numbers because it only goes to June 21, but since then the trend in terms of percentage numbers has probably continued, and we are about 80% non-COVID patient with a very consistent, significant COVID caseload. And we've managed, as you can see, to do actually one of the largest number of liver transplants. These are adults only, so excluding pediatrics during last year and this year, also by virtue of other centers being unable to provide any ICU support post-transplant. So the only patient transplanted in the country nationally were conducted at times at King's. Last slide. So I think it can work. Obviously, we have to live with it. It's becoming an endemic disease. and it will not remain the only viral pathogen of concern and beyond this and next year. So there is a potential of running certain types of work through a only green hospital, potentially also with the help of the independent sector, which has been facilitating that kind of work during second and third wave in this country, but also within tertiary, multi-specialist and emergency settings combined. And we've talked about the prerequisite to make this happen, and this is how I finish. Thank you very much.
Thank you, George. You know, I recognize we are over time, so do you want to defer questions? And I leave that up to you, George. Should we just move on to the next session?
I think we should, and I'll invite Luigi to introduce the next session, if that's okay. Thank you so much.
Thank you, appreciate it. Thank you for all the speakers.
Thank you, everyone.
Thank you, everyone. It's been a great session so far. And my name is Luigi Camporosa from London, and I've got the privilege now of introducing the next section on trials, on pharmacological trials. And I've got the pleasure of introducing the two chairs, Dr. Daniel Culver, who is a director of the interstitial lung disease at Cleveland, Ohio, and my friend, Professor Manu Shankar-Hari, who is professor in clinical care medicine and NIHR clinical scientist. There's done lots of research in COVID-19, and the last one he's been chairing the WHO rapid appraisal for IL-6 antagonists. So over to you, Daniel and Manu.
Luigi, thanks very much for that lovely introduction and the invitation to kind of join this wonderful seminar. Without actually taking too much time, I think I will get the co-chair and the speakers on. I just want to say one thing, you know, randomization gives you the causal effect of a treatment on an outcome. No other kind of study design achieves that. So over to the speakers for enlightening us on the interventions. Thank you.
Thanks, Manu. It's a pleasure to be here. I'm not going to say much here either, except to say that this has been a very fast-moving situation. It's a moving target with new VOIs and VOCs emerging. The way we apply the data from these trials, I think, is a challenge. As we think about combination therapy, and subpopulations were challenged. And so each of the speakers is going to show you the data from the trial, but then take it the next step and talk about how this is going to apply as we move along. So with no further ado, I'll ask each of the speakers to introduce themselves in 5 seconds or less, and I'll turn it over to Dr. Matsuba and Dr. Seth Bauer. I want to point out in this session, actually, it's a very nice exposition of the importance of our PharmDs in critical care. And PharmDs really are leading the way along with the physicians in how we manage this pandemic. So Matt and Seth, it's all you.
Great, thanks a lot, Dan. It's a pleasure to be here today. Very happy to discuss steroids and COVID-19, recovery and beyond with my colleague from pharmacy, Seth Bauer. Can we go to the next slide? Our disclosures are listed here. I don't have any, except I was probably chosen to speak for this because I'm like a pro-steroid person. So I would just, first of all, want to just thank the United Kingdom for saving the world by running the recovery network. That's much appreciated. Finally gave us a viable treatment and the first of its kind. Fortunately, it was built on some plausibility based on prior studies, but what we'll talk about here is, of course, we're all familiar with recovery trial, which is an open label trial comparing steroids to usual care in patients who are hospitalized. As you can see here, the breakdown is divided by invasive ventilation, oxygen, or no oxygen received. 16% of the patients in this study were ventilated. For those of us who work in critical care, that's probably most relevant. 60% of the patients were on oxygen, and then the remainder were not receiving oxygen. As you can see, there's maybe a signal towards harm in the group that was not receiving oxygen, but in this study, we're defining requirement of supplemental oxygen if your oxygen saturation was less than 94%, but still in aggregate, you can see there's a benefit in terms of mortality. Additionally, you'll be more likely to wean from invasive mechanical ventilation, less likely to require renal replacement therapy if treated with dexamethasone at the 6 milligram dose for 10 days, as was done in this study. Next slide. Taking this study into account with other studies that involve purely critically ill patients, the WHO REACT meta-analysis results are displayed here. You can see in a fixed effects model, we still have preservation of the improvement in mortality compared to usual care. And moving on to the next slide. There are some really interesting subgroup analyses in this study that were pre-specified. One in particular shown here is the higher likelihood of benefit to steroid therapy if somebody was requiring vasoactive therapy. You can see the odds ratio there of almost 2, favoring the higher benefit here, which is really consistent with what we've seen in past trials such as adrenal and other steroid trials for people who are on vasoactive medicines in terms of their ability to wean from the ventilator, and also possibly mortality benefit. The other things to consider, other subgroups that were evaluated that are worth mentioning, there was actually in this meta-analysis a greater benefit to those who were not receiving invasive mechanical ventilation than compared to those who weren't. The ratio of odds ratio of 4.34 in that case. A little bit surprising, but perhaps we're just catching people at the right stage of the illness in that case. There were no detectable differences in the magnitude of benefit based on age, biological sex, or duration of symptoms, with a cutoff being greater than or less than 1 week. So overall, the initial look at steroids suggests a benefit towards mortality, time off the ventilator, and some other secondary outcomes. And now I'll turn it over to Seth Bauer to discuss some more interesting implications of these findings.
Thanks, Dr. Shuba. I think you nicely outlined the overall benefit of steroids, but I think we also have several remaining questions with these medications, notably within certain subgroups of patients, particularly patients that may be receiving adjunctive medications or within population-specific criteria. The difference in odds ratios between invasive mechanical ventilation patients and non-ventilated patients beg the question of whether we need population-specific regimens and whether or not certain drugs, doses, or durations need to be modified for certain populations. And I'll just highlight the most critically ill patients on the next slide. The original, next slide, please. The original dexamethasone dose studied in recovery was 6 milligrams daily for 10 days, as Dr. Shuba mentioned, but alternative regimens have been evaluated for severely ill patients. One in the Codex trial published in JAMA last year, and another in the COVID steroid 2 trial that is published as a preprint just a few weeks ago. Next slide, please. I think we're all familiar with the recovery trial and the regimen. Specifically evaluating the mechanically ventilated subgroup, we can see here the relative risk for death was 0.64 with a 95% confidence interval that did not include 1. This was a large population, even within the mechanically ventilated subgroup. However, there are questions on whether this is the right dose or not because the comparator was only placebo. In the Codex trial, they included a relatively smaller population, but specifically evaluated patients with early moderate to severe ARDS and used the same dosage regimen as outlined previously in the DEXA-ARDS study, which is dexamethasone 20 milligrams daily for 5 days, followed by 10 milligrams daily for 5 days. The study was primarily designed to look at ventilator-free days and found significantly more days in the dexamethasone regimen compared to placebo, but the study wasn't powered to detect a difference in mortality. Interestingly, the COVID steroid 2 trial specifically wanted to evaluate hypoxemic patients who were mechanically ventilated and looked at higher doses of dexamethasone at 12 milligrams a day versus 6 milligrams a day. There's indication in this study that the higher dosage led to improved outcomes for patients, but the confidence intervals include 0, and so there will be interesting interpretation of this study. However, I would just like to point out that these 2 additional studies besides recovery do point out that 6 milligrams daily of dexamethasone may not be the optimal regimen for every patient, and we need further studies to evaluate potentially the illest patient. Thank you. Next slide.
So I'm going to go ahead and get started. Oh, go ahead.
Yeah, go ahead, Gretchen. We'll save all of the questions for the end, assuming we have time.
Okay, sounds good. No problem. My name is Gretchen Sasha. I'm one of the critical care pharmacists who practice in the medical ICU at Cleveland Clinic main campus. I've been rounding on our COVID teams and treating these patients since the beginning of the pandemic, and I'm honored to be invited here today to give just a brief discussion, as we all know, on IL-6 inhibitors in this disease state. Next slide, please. I don't think I need to dwell on the rationale for the use of IL-6 inhibitors in COVID to target one of the key drivers of inflammation that can be occurring in these patients. Tocilizumab is the most prevalent agent studied and utilized, and it's a humanized monoclonal antibody that binds IL-6 receptors and results in inhibition of IL-6 signaling. Its utilization throughout the pandemic has been a little polarizing, and like many agents, has changed dramatically as new literature gets released. So early, primarily retrospective studies seem to show a benefit in the critically ill patient population. However, early randomized controlled trials conflicted these findings, and its use fell out of favor as a result. Next slide, please. What is important to note is that these early trials, and these are the randomized controlled trials, included Corimmuno-19, backed by tocilizumab, RCT, TCZ, COVID-19, and Impacta, all excluded patients who were requiring non-invasive and or invasive positive pressure ventilation. It's also important to note that in all of these studies, except for Impacta, only a small portion of included patients received steroids, and no difference in clinical outcome was detected in any of these three trials. So now when we look at the Impacta study, which was conducted later in the year after the release of the dexamethasone arm of the recovery trial that was just mentioned, over 80% of the included patients in this study received steroids, and they did find a reduction in their composite primary outcome of mechanical ventilation and death. So it seems from these trials that in the non-critically ill patient population, tocilizumab maybe provides little benefit, but maybe some benefit in those patients receiving concomitant corticosteroids. Next slide, please. Now, more recent prospective studies change this picture even a little further. So enter the REMAP-CAP and the tocilizumab arm of the recovery trial. Both were published in early 2021. These trials differed from the previous trials that I mentioned on 2 points. So first, they actually included critically ill patients and those requiring non-invasive and invasive ventilation. And these patients had elevated inflammatory biomarkers at study inclusion. And more than 80% of the included patients received corticosteroids. So briefly looking at the results, you can see that in the REMAP-CAP trial, patients who received TOCI had more organ support-free days and numerically lower rates of in-hospital death. Now in the tocilizumab arm of the recovery trial, which included over 4,000 patients, 28-day mortality was lower in the group of patients who received TOCI, as was the number of patients who ended up requiring invasive mechanical ventilation. And additionally, more patients who received TOCI were discharged from the hospital alive. Now, the most recent publication to note is a meta-analysis that was published in JAMA recently that evaluated the various IL-6 inhibitors in 27 different studies for COVID and found similar findings to what we're just discussing, an association between their use and reduced 28-day mortality. Based on these studies, I think it's appropriate to recommend utilizing tocilizumab in patients who are critically ill that require either non-invasive or invasive positive pressure ventilation that have elevated biomarkers. Our cutoff at the U.S. Cleveland Clinic facilities being a CRP of 7.5 milligrams per deciliter. Next slide, please. And because nothing is ever easy during a pandemic, I want to touch on the current state. Unfortunately, because the data that we discussed led to an increase in the utilization of TOCI, there is a shortage of it that was announced last month with no estimated release date. So some centers are experiencing limited to no availability of this medication. And now, although not a direct IL-6 inhibitor, I do want to take this opportunity to very briefly mention baricitinib, which is a Janus kinase or JAK inhibitor. By inhibiting specific JAK receptors in human leukocytes, it blocks IL-6 mediated phosphorylation. At our U.S. facilities, we've begun using baricitinib in patients who would otherwise be receiving tocilizumab but can't because of this drug availability. And the studies that published evaluating baricitinib are the ACT-2 and the Cove Barrier trial. In ACT-2, which was published in December of last year, baricitinib was studied in combination with remdesivir and was found to improve recovery time compared to remdesivir alone. And then in Cove Barrier, which was published earlier this month, it was compared to placebo, although almost the entire study population was receiving dexamethasone. And in that study, this was baricitinib use was associated with reduced 28-day mortality and was of most benefit in patients requiring high flow or non-invasive ventilation. So because of these studies, baricitinib may be considered as an alternative to toci when it's unavailable, but it is important to note that to date, there has not been a head-to-head study comparing these two agents. Next slide, please. Now, the final piece that I want to mention is sarilumab. This is another IL-6 inhibitor, mechanistically similar to tocilizumab, that may be considered as an alternative agent in the setting of this continued toci shortage. Sarilumab was included as an intervention in the REMAP-CAP trial that I previously discussed. And when compared in that study to tocilizumab directly in a preprint trial, you can see that the results were overall similar in regards to organ support-free days and in-hospital death. Additionally, this trial reports a 93% probability of equivalence between both of these agents. So because of this, I believe it is reasonable to recommend and utilize sarilumab as an alternative to tocilizumab if this agent is available to you. However, I personally would put preferential use on baricitinib just due to the amount of data that's available with it, which I believe is a little bit stronger than the data for sarilumab. Now, I know that was a really rapid fire discussion of the IL-6 inhibitors, but I hope it provided some insight. And thanks again to the panel for inviting me today.
All right. So thank you for the committee for inviting me to present. Can you all hear me? Okay. So I'm going to talk about interleukin-7 and interleukin-1 beta modulation in COVID-19 next. I have a few disclosures. The one most relevant to this presentation is I am a site PI for ILIAD-7, which is a trial that is ongoing for the use of interleukin-7 in COVID-19 patients. And I am funded by NIH. I've got two ongoing R1 grants as a principal investigator, one as a co-I. Next slide, please. Okay, so let's talk about IL-7 in COVID-19. Next. So we all saw these publications earlier on, long time ago, like back in February 2020, it seems that long ago, that a JAMA network came out, this study from Wuhan, China, that lymphopenia is associated with, in COVID-19 is associated with mortality. And back to back, a second article came out in Lancet in March that non-survivors continue to show lymphopenia. So it's just not one-time thing that patients who do not survive continue to show continued lymphopenia. So lymphopenia is bad in COVID-19. We knew this phenomenon from other disease processes in critical care, as we all know. In sepsis, we knew that IL-7 is that lymphopenia occurs and it's bad. And interleukin-7 was known to decrease lymphocyte apoptosis, which has been shown to improve lymphopenia in sepsis. So next. So there was a lot of enthusiasm about studying interleukin-7 in COVID-19. Next slide. Okay, so initially interleukin-7 was used as a immunotherapy as a compassionate use. And the investigators from Europe put out these reports about the 12 critically ill COVID-19 patients they enrolled as a compassionate use, of course, so this was not randomized. The patients had to have 2 consecutive absolute lymphocyte count less than 700. And the dosage was twice. They gave interleukin-7 itself twice a day, intramuscularly, twice a week, I misspoke, for 2 weeks. And next. And they showed that the absolute lymphocyte count actually increased before that, sorry. So the absolute lymphocyte count increased in the IL-7 treated group versus the control. And when they split that analysis, IL-7 survivors showed the most sort of lymphocyte count benefit, if you will. And so there was a lot of enthusiasm next, but this was a single center study. And so next slide, please. So the randomized control trial was designed and it is still ongoing. It's called ILIAD-7. This is a multi-center, multi-continent study, and we are still enrolling patients for this. So the results are awaited. Next. Now I'll switch gears to interleukin-1 beta and COVID-19. We all know about the cytokine storm. And so there were a lot of case reports and case studies about encouraging reports about IL-1 blocker one way or another. And so a randomized controlled trial was taken up. Canakinumab is a IL-1 beta monoclonal antibody, and so it directly inhibits the IL-1 beta. A randomized controlled trial in COVID-19, 39 hospitals in Europe and the US, over 400 hospitalized patients within 7 days of diagnosis. It was a single dose given intravenously, but they saw no survival benefit. And next. Similarly, anakinra, which is an IL-1 receptor 1 antagonist, it's a competitive inhibitor of IL-1 beta because it binds to the receptor 1. And this, again, case reports were encouraging, but a multicenter open label trial, CORE-Immuno ANA1 from the same group as Gretchen mentioned, usual care versus anakinra versus anakinra versus usual care. It was stopped early because per DSMB recommendations because it did not show any improvement in the outcomes of mild to moderate COVID-19 disease. Next slide, please. So in conclusion, interleukin-7 in COVID-19, it's an ongoing randomized controlled trial and the results are awaited. And in IL-1 beta, canakinumab, no benefit, and anakinra also no benefit. Next. With that, I would like you all to thank you.
Thanks, Vidula. Now we'll turn it over to Simon to talk about a very controversial topic, which is plasma therapies. Dr. Muka.
Yeah, thank you for having me, and I hope that by the end of this talk, maybe this will be a little less controversial. So thank you. I'm happy to talk about the trials aspects of plasma therapy. Next slide, please. A little bit of background. There are some case series from prior influenza and SARS outbreaks and historical evidence that maybe convalescent plasma and hyperimmune IgG might be beneficial. In the United States, the vast majority of convalescent plasma was used as an open label treatment outside of any clinical trial, initially through the expanded access protocol. And then retrospective data gathered from this expanded access protocol was used to justify emergency use authorization in the United States in August of last year. Overall, there's over 150 international or interventional trials on convalescent plasma registered on trials.gov. The vast majority of these studies never completed. Many of them were stopped early because there was difficulties enrolling because many patients, at least in the United States, had already received open label convalescent plasma. Patients would refuse enrollment in clinical trials because plasma was available through the expanded access protocol or later the EUA. Or others because they found that many patients had positive antibodies at the time of enrollment. There are other trials going on other therapies such as plasma exchange or cytokine absorption therapies. However, none of these are large and the vast majority remain unpublished. So in this talk, I really focus on key trials, and there's 4 of them that I want to highlight in this talk and hopefully squash any persistent controversy on this topic. For the outpatient setting, I'm going to talk about the C3PO study. And an inpatient setting, including hospitalized and critically ill patients, I'm going to focus on recovery, Concord-1, and the Pass It On study. And in full disclosure, the Cleveland Clinic did participate in the Pass It On study, and we enrolled patients both in our Ohio and Florida locations. Next slide, please. The C3PO study was done in the United States. It enrolled 551 patients in emergency departments. Inclusion criteria were patients had to be 50 years of age or older and have additional risk factors for poor outcomes. They had to present within 7 days of symptom onset and deemed to be stable for discharge and treatment as an outpatient. This was a randomized 1-to-1 placebo-controlled study. The Primary outcome was development of severe disease defined as respiratory rate of greater than 30 and a new oxygen requirement. The study was halted early due to futility, and 30% roughly in both groups progressed to severe disease. So this study failed to reproduce either the observation or the prior observational studies that suggested benefit and other small randomized controlled trials that suggested possible benefit for early use in at-risk patients on the outpatient basis. So based on this, there's no evidence to continue to use plasma in the outpatient setting. Next slide. The convalescent plasma arm from the recovery network enrolled almost 12,000 patients that required hospitalization in the United Kingdom. This was a randomized open-label 1-to-1 controlled trial of plasma versus usual care. Primary outcome in the study was 28-day mortality, and there was no difference between both groups. Overall, 24% mortality in both. Interestingly, again here, the majority of patients, 62%, had antibodies against SARS-CoV-2 at the time of enrollment. And even in the subgroup of patients that were antibody negative at the time of enrollment, convalescent plasma did not offer a benefit. One important caveat here is this study used the Euroimmune IgG spike protein ELISA to qualify whether or not this convalescent plasma was deemed anti-SARS active. This supposedly, the titer used in this study supposedly correlates with a neutralizing antibody of 1 to 100. And these antibodies become important when we look at the next study. Next slide. This is data from the Concourse study that just released last week. It's a study conducted in Canada, the United States, and Brazil. It enrolled 940 patients that required hospitalization due to hypoxia from COVID-19 with symptoms less than 12 days. Randomized 2-to-1 plasma versus usual care. The primary outcome was intubation or death, and this study found no difference in the primary outcome. But more important than the primary outcome that was no different between the groups is something that's highlighted here on the right in the panel. This study was able to correlate the antibody titers in each unit transfused with the outcomes of the patients that received that specific unit. As you can clearly see on the bottom, there's a uneven distribution of antibody titers, and in the top graph, it shows that the relative risk of the primary outcome, which is death or mechanical ventilation. And clearly, the risk of death or mechanical ventilation decreases as the titer of antibodies increases. But more important than recognizing that there's sort of a dose relationship between the antibody titer and outcome is the dotted line that you see on the top part of the panel. This is the one, which means this is the mortality of the control group. So it is important to note that patients who received low titer and convalescent plasma in this study have a statistically significantly higher risk of adverse outcomes. So this study shows not only a direct correlation between the antibody titers and viral neutralization of the antibodies in the convalescent plasma, but does show a signal for potential harm for patients who receive low titer plasma. It's very interesting because the data retrospectively from the expanded access protocol suggests that a 30% relative risk reduction of mortality for patients who received high convalescent plasma or high titer convalescent plasma. In hindsight, looking at this data, maybe the retrospective data from the expanded access protocol didn't show benefit for high titer convalescent plasma, but has so much misinterpreted harm from low titer convalescent plasma. Next slide. Finally, the Pass It On study, which is a study that we participated in. This enrolled patients hospitalized with respiratory failure and randomized patients in a double-blind fashion 1-to-1 to plasma versus placebo. Primary outcome is functional status on the ordinal scale at day 14. We have completed enrollment at about 950 patients. We have now finished the observation for the final patients who've been discharged from the hospital, and data analysis ongoing, and we should have results shortly. I do want to point out the way plasma was collected for this study because this highlights as a key difference between studies. On the right, you see a little bit of a flow diagram. In order for plasma to be used in the Pass It On study, it was first screened for the presence of antibodies. Then it was undergoing additional testing with an ELISA, and only tight antibody samples or plasma samples that had high ELISA antibody titers were then selected for a final screening step to test directly for viral neutralization. So in this study, only plasma that had a high titer of viral neutralizing antibodies was used in this study. So hopefully this will be the definitive study on whether or not there's any role for convalescent plasma in the hospitalized patient population. Next slide. So my key takeaways for the use of convalescent plasma is that randomized controls trials failed to confirm benefit that was reported in early case series and observational studies. Convalescent plasma does not prevent progression to severe disease in those who have mild disease. Convalescent plasma does not benefit the critically ill. And convalescent plasma, in my opinion, is now an example of the inappropriate early adoption of unproven therapy. And the broad use of convalescent plasma through the EAP was unwarranted and in hindsight may be potentially associated with harm. Any remaining questions about whether or not viral neutralization of convalescent plasma has effect on outcomes will likely be answered by the Pass It On trial, and I'm looking forward to hopefully sharing the data with you all soon. Thank you.
Thank you very much, Simon. Good points. I'm happy to introduce Dr. Bimraj. We've successfully surmounted the technical difficulties through geographic proximity between ID and critical care. Dr. Bimraj has been a leader in this pandemic. He's the head of the IDSA guidelines and has some interesting perspectives from IDSA on where we go next. So I'll turn it over to you, Darsh.
Thanks, Dan. I'm sorry if you're expecting to see Simon. I think I'm not as smart, not as good looking as him, so I apologize for that. So I'm going to delve in. I think you had some amazing talks summarizing the evidence of existing therapies. I'm going to talk about what are the lessons that we have learned from COVID-19 treatments. I think some of the speakers have already alluded to it. So COVID-19 was a, pandemic which actually tested us, but I think we came up with great solutions, platform and adaptive trials, which answered critical questions amidst the pandemic. But there are things that we could have done better. And again, hindsight is 2020. It's not to find fault with these trials, but how we can do better for the future pandemics. Next slide. So I'll start off with what are the outcomes that we studied in the trials and what could we do better? I think most platform trials studied mortality, but I don't think we did a great job with the non-mortality outcomes. We think it's really important for the future trials that we measure clinically meaningful patient important outcomes, not just 28-day outcomes, but 60-day outcomes. Like what if somebody was on a ventilator and died at day 60? I think and even just outcomes like mortality or non-mortality clinical outcome, but disability. There's a lot of talk about long COVID, and I'm not talking about memory issues and with fatigue, but shortness of breath because of lung damage or things like that. I think we need, do these therapies actually change the long-term outcomes? Another outcome that we have kind of not talked about is transmission, especially in ambulatory patients. Does using antibodies actually decrease transmission in household contacts? And hopefully adjusted for other confounders for transmission. In a pandemic and epidemic, that's an important outcome. And what shouldn't we have done is I don't think we should use composite outcomes, especially combining heterogeneous clinical outcomes or using location. I'll illustrate these 2 bullet points in the next slide. Next, please. So what you're seeing on the screen is the NIAID ordinal scale that was used in Act 1. And there's similar ordinal scales that are used in multiple trials during COVID-19. And even the WHO ordinal scale is similar. As you can see, 8 is death, and 1 is not being in a hospital without any limitation or activities. And you have different shades or grades of severity of COVID-19 in between. So a lot of the trials used a 2-point improvement on the scale. Like if I was in ECMO and I can transition to supplemental oxygen, I get 2 points. But if I was in supplemental oxygen and I'm just sitting in a hospital to get discharged, I just get 2 points. I think most people disagree that this 2-point improvement on the scale, depending on where on the scale, are not equal, most patients and providers. And unfortunately, that's been something that was used extensively. Next. Another thing that people have, especially in Act 1, they've used is like using, discharge time. Again, in this trial, if you're either sitting in a hospital waiting to be discharged or discharged, and we called it recovery time and time to recovery, But I want you to be mindful, like, and especially in a crisis capacity, when a patient gets discharged or how long somebody stays in a hospital is provider dependent, patient dependent, policy dependent, and crisis dependent. So I think we should transition more to like our patients on ventilators. I think it's a meaningful outcome. Our patients in supplemental oxygen and actually hypoxemic, and each of these outcomes can be individually studied. We have enough patients in a pandemic rather than using composite outcomes. It has made it extremely difficult to interpret and translate these into clinically useful tools because of these outcomes that have been studied. Next slide. And I'm going to switch over to what populations to be studied. And majority of the patients without comorbidities or young have mild to moderate disease and improve with supportive care. It's the older patients and the one with high-risk comorbidities that progress to severe disease or death. I think a lot of the trials, the earlier trials like the bamlanivimab trials, did not study high-risk patients. It was difficult, but luckily the bamlanivimab, etesevimab, and the casirivimab later picked high-risk patients. And I think it's necessary, at least up front, that they do studies in patients with high risk who will actually benefit more from these trials. And later on, maybe they can try in the low risk patients. Next slide. And also, not all therapies will work in all types of patients and clinical phenotypes. And I think tailoring therapies to phenotypes, I think, is important. And timing of therapies, I'm talking about biologic and immunologic time and not just chronologic time is important. As you can see in this slide, like things that target the virus like remdesivir and monoclonal antibodies are effective early on, whereas where your own immune system has not kicked in and your viral loads are high. But later on, whenever you have an aberrant immune system, especially immune response, things like dexamethasone will be helpful. Next. Sorry, my slides are a little slow. But as you can see over here, most of the drugs which have shown any kind of mortality benefit later on in disease have been targeting the immune phase, like dexamethasone, the IL-6 inhibitors, or the JAK inhibitors. Next slide. So even within those group, I think specific clinical phenotypes and biomarkers can predict severity and even response to therapy, like viral loads, antibody positivity, or CRP levels. I don't think we have done any kind of heterogeneous drug response trials to answer that. The casirivimab, imdevimab recovery trial showed that if you're seronegative, there's a mortality benefit, slight mortality benefit, but if you're seropositive, there wasn't. Next. And this is pooled data of the tocilizumab trials that have been presented. If you see all the earlier trials, and some of them which did not target CRPs, did not show an effect, but later trials like Gordon and Hobie showed an effect. They were used in critical disease, but early on, and with an inflammatory phenotype. And even then, again, how do we use it with dexamethasone? Clinically, it has become so hard to translate the results of these trials as to which patient we have to use in. I'm hoping the future trials can actually upfront in the trial design have a stratification by biomarkers and then see which particular subpopulation of patients will best benefit. Next. Next. So finally, I think, what do we go back, please? Yeah. What do we do during a pandemic? As again, there's a lot of data that's generated, but I think it has to be synthesized, appraised, and disseminated the right way. So for that, I think we need pre-trial establishment and collaboration between large trials to do individual patient-level meta-analysis, agreed upon outcomes. An example, even though it was study-level outcomes, is the WHO REACT group, which took data from all the steroid trials and they published it in JAMA. And I'm hoping we could have done a much better job for other agents if we had these. And the collaboration should not be not just between the groups that do meta-analysis, but also the ones that do rapid living guidelines like the IDSA and WHO. And they should use a systematically established and trustworthy methodology like GRADE, and then you hopefully foster collaboration so that we can best utilize scarce resources and expertise in a pandemic. Wouldn't it be better for the ID societies to concentrate on pharmacotherapy and the critical care societies on oxygenation ventilation? It takes a lot of effort to do these meta-analysis. That way, I think we would have used our stretched resources much better. With that, I think I'm going to conclude saying that we have done a great job, but I think there's room for a better job in the future, not just during pandemic settings, but there are lessons we can learn for non-pandemic setting. And I'm hoping, like Peter Hobby, who has done the recovery study, for which kudos to the UK, is we can make clinical care, again, research a part of clinical care as part of routine care and generate much needed evidence for many issues if we follow some of these lessons that we learned from COVID-19 trials. Thank you.
Thank you, Adarsh. That was a wonderful synthesis of all of the information and all the lessons we've learned. And I think, you know, this started off as a simple process to study a viral infection. And it's, like everything in life, it's more and more complex the further along we go. There is a question here from the audience, and I'll throw this out to the entire panel. I think we have time for at least this one question. It says, regarding convalescent plasma, some have suggested that there may be a benefit in some severely immunocompromised patients who are not expected to mount antibody response, such as transplant patients. Can you comment on that, Simon, or anybody else?
Yeah, that's an important question, and that is probably the one group of patients that we continue to get requests to use plasma. I think one of the concerns about convalescent plasma is that not all plasma is created equal, and we don't really know what is in the plasma. Early in the pandemic, we didn't have any antibody screening tests. Throughout the pandemic, some of our ELISAs were showing that they may be correlating with viral neutralization, but the correlation was poor. And then I think there's a growing concern that whether or not plasma that's collected early in the pandemic is still active against evolving variants. So there's, I think, more questions about plasma than there are answers. I think the patient population that is immune suppressed, you know, severe lymphocyte depleting chemotherapy, the multiple myeloma patient that, you know, persistently have viral shedding and are not mounting an immunosuppressant, I think that would be the one population that one could argue. I think that what argues against convalescent plasma, it is dependent on a donor. And there's been small studies that look at, even in the expanded access protocol kind of population, that patients who receive plasma from donors that lived further away than those who lived closely had less of a response or had worse outcomes, suggesting that really a regional heterogeneity in the donor pool is important. So I do believe that, you know, if you don't mount an antibody response, plasma might be an option. But again, the data to support plasma and the questions that are around the efficacy of the plasma itself are just still looming large.
Thank you, Simon.
I'm here, Dan, is like, again, instead of plasma in that same population, why not look at monoclonal antibodies, right? Because you have very high titers of specific antibodies, and you know, based on the recovery study, that seronegative patients from benefit, and again, there won't be any supply issues and other issues rather than unlike convalescent plasma in the same population.
Thanks, Adarsh. Yes, lots of questions and plenty of more room to do more studies. Well, I want to thank all the panelists and thank the audience for your interest. I think in the interest of time, we should stop right there. We could talk about this certainly all day long. In the absence of any further direction, why don't we plan to come back in 15 minutes? Georg.
No, I'm good.
Thank you so much, Daniel, for chairing the session now on your own. Manu had to drop off for another meeting. We've run a little bit over, but you know, everybody was really great trying to keep within schedule. We will have a 5 to 7 minutes coffee break, and we'll try and resume at 5 to 4. I hope that is acceptable. Thank you very much.
Okay, so welcome back to the next session as we move into Friday afternoon, and I'm sure others are moving along with their days too. So this session is all about immunomodulators and anticoagulation in COVID-19, something we found to be very important and challenging. And the questions are asked when, how much, and in whom. And I'm going to hand over to the faculty here, which is Simon Mucha, Beverly Hunt from the UK, Vivek Karkar from Abu Dhabi, and Jinesh from Cleveland Clinic, Florida.
Thanks, Nick. I don't think all faculty have joined yet. I know Professor Hunt was having difficulty joining in. Oh, Simon is on.
If you guys want to start,
Okay. Simon, do you want to run the last slides, or shall I run through the slides?
Why don't you start, and then we'll discuss it as a group, I think.
Right. Well, hello, everyone. Welcome to the roundtable session on immunomodulators and anticoagulation in COVID-19. My name is Vivek Kakkar. I'm one of the intensivists at Cleveland Clinic, Abu Dhabi. I'm joined here with the experts from all over the world. I'll let them introduce themselves to you. Dinesh.
Hi, I'm Jinesh Mehta. I'm one of the pulmonary intensivists at Cleveland Clinic, Florida. And by no means any expert on this, just trying to learn with everybody else.
Simon.
Yeah, hi, I'm Simon Muka. I'm an intensivist in Cleveland Clinic, Ohio. I'm also by no means an expert, but is very fortunate to obviously learn throughout the pandemic. And I was involved in some of the anticoagulation studies here. We're part of Active 4, which is an important study group in anticoagulation, and obviously the plasma studies. Thank you.
Prof. Hunt needs no introduction, but I think your mic is muted, Professor Hunt.
I think you are on now, Beverly. Could you try again, or no? If you try and press the unmute button on your...
Yeah, it should work now. Oh, someone is singing. Yes. Okay.
Ah, hooray. Hello. Beverly Hunt from London. I'm at Guy's and St Thomas's. I sit on the NICE Living COVID Guidance and the WHO Living Guidance, and I work with the Royal College of Obstetricians on their guidance, and I was part of the anticoagulation trials. Hi.
We don't have that many slides, which is a good thing because I haven't slept over 36 hours. So if I say something that's off topic or kind of slide, I'm sure you will correct me. So, I mean, this is where we were at the beginning of last year in April. These are the guidelines from NIH, and you can see it. There's essentially nothing in there in terms of pharmacotherapy targeted at COVID-19. Next, I think in the last 18 months. Next slide. In the last 18 months, every bit of pathophysiology of COVID has been dissected and targeted and investigated. And some of the more prominent targets that have either made into clinical practice or are currently the focus of more deeper investigation are highlighted in green, including convalescent plasma, monoclonal antibodies, TNF inhibitors, interleukin-1 and 6 antagonists, and the interferon gamma and GM-CSF inhibitors. But actually, the robust evidence is only available for a few of them. Next slide, please. And which you can see in the severity-based guidelines from the NIH that was last updated in August 2021. And the only medications that are in there are remdesivir, dexamethasone, tocilizumab, and baricitinib. And the choice of agents depends on the severity of illness. So I will stop there, and I think I'll put a few questions there that we can probably discuss and then see where the discussion takes us. Next. So, I mean, looking at these guidelines, I think what we should probably just discuss is, do our practices still vary across the globe? I know that we are mostly following guidelines as they are in this table at our center, except perhaps steroids for the sickest of our cohort. I don't know if you guys are also doing the same in your centers.
Yeah, we're following the same guidelines that you put up there. Initially, it was a lot of unknowns and a lot of what should we do for these patients. Stick with the basics of ARDS management, stick with the basics of sepsis management, and then as the data came along with dexamethasone and then remdesivir and now the IL-6 inhibitors, we've been expanding our protocols, mirroring most of what is on the one MICU protocols that Cleveland has put out, and trying to stick with those protocols as best as possible.
And the same, I suppose, the same for you, Simon.
Yeah, I think I'll highlight that again, similar to what Dr. Sasha and the other talks prior highlighted is, we do use steroids. We usually use the 6 milligrams. And in the absence of great guidance of when and how to use higher doses, I think our practice has been to stick to the 6 milligrams of dexamethasone. And then, just like it was outlined, we use remdesivir. And with the inclusion criteria of having inflammatory markers, which is the CRP of 7.5 milligrams per deciliter, which were the inclusion criteria in the recovery trial, which is the data upon which we built our practice. And then again, unique, I guess, to a practice in a pandemic is that we are now utilizing the JAK inhibitors because there's a clinical shortage of tocilizumab. I think it would be great to have, a panel of maybe markers or biomarkers that could tailor our therapy a little bit more closely to the individual inflammatory profile, or more specifically. But I think we may be getting there in the future, but as of now, there's not a real robust set of targets that we can say measure and maybe adjust our therapy to.
That's an interesting point, though, because we're using so many agents along the cytokine pathway. And interleukin-6 monitoring for the first time has been spoken about so much. And I know at our center, we were using interleukin-6 monitoring quite a lot, actually. And also for our sickest ventilated patients and all our ECMO patients, we use higher dose methylprednisolone. And what was interesting to see was that in all of these patients, the interleukin-6 dropped quite precipitously after the first day or so. So we found in our second wave, we didn't have to use tocilizumab once the IL-6 was down, actually, within 24-48 hours. So, I mean, so the question in my mind is, what wasn't established so far was whether COVID ARDS is steroid responsive or not. And once we know that it is steroid responsive, then why not higher dosing, as was earlier suggested by CCME, SICM for the non-viral ARDS? In fact, there was
Sorry, Vivek, can I ask a question, maybe bring Beverly into the discussion? Maybe inflammatory question, just to stimulate discussions, but the problem I always had is we've suddenly seen a huge number of patients who were all ventilated for a long period of time, be it that, their inflammatory phenotype is different to other patients who've got ARDS with bowel disease and are on the ICU. We've done lots of diagnostics on these patients, which sometimes we may not do for other ICU patients, and we suddenly found a high incidence of thromboembolic events. But I just wonder whether or not the baseline incidence in all other patients is indeed, if we were to investigate them as much as we've done in this situation, not a lot higher than we think. That's the first question. The second one, I would just really be interested to hear your opinions on is, I sort of get the feeling that there is different phases, possibly related to the different therapies we've been implementing, where my very subjective impression is that we have many more bleeding complications during the first wave, or more at least, I'm calling it. In the last wave, it appears to me that we see less of that. Is that something which other people seem to have experience with as well, or is it just my subjective anecdotal view?
Shall I start? I mean, the first thing to say is that we have done a study, Luigi was part of it, where we looked at patients before they went on to ECMO, I mean, obviously the severe ones, and we always do a CTPA before we put patients on ECMO. And we compared what we found on the CTPA with other viral pneumonias we've seen over the last 8 years, and there's about 80 of them, mainly H1N1. And if you look at them, we are seeing with COVID higher rates of changes on CTPA. And I think people got a bit muddled to start with COVID, because the issue was they saw lots of changes on CTPA and they said they're pulmonary emboli, and they're not, because some of them are just segmental or subsegmental changes which probably reflect immunothrombosis, which is part of ARDS. And so when you look and compare with other viral pneumonias, you've got a higher rate of overall changes. When you compare the segmental, subsegmental changes, the isolated ones, it's still higher than other viral pneumonias. And the other thing that we do where we've got a comparison is when they come off ECMO, we do a Doppler ultrasound of the legs to look for DVT, and again, much higher rates with COVID. And so for me, COVID is really prothrombotic. These were the early patients before they got systemic steroids, and we were seeing incredibly high levels of fibrinogen. I've never seen them like that before. And yes, I mean, we never really looked very closely at other patients with ARDS from the coagulopathy viewpoint, and other patients with viral pneumonias do have a coagulopathy, there's no doubt, but it's not as severe as with COVID. There's something about COVID, it's sparking off all aspects of the coagulation pathways. So when I look at this NIH COVID treatment guideline, I think there's a big omission here, and that is thromboprophylaxis, because it's so important. And of course, we have to then move on to the trials that obviously were all combined. They combined the 3 different platforms. Simon was involved with ATTACK, I was involved with REMAP-CAP, and they showed that comparing full dose anticoagulation with standard of care thromboprophylaxis showed that full dose anticoagulation was of no benefit clinically, using a 21-day endpoint in those in critical care, although it was in those with moderate disease, so those on the wards. And then we've got the Inspiration trial, which compared intermediate dose with standard dose, which shows no benefit of intermediate dose versus standard dose, and like the big trials, shows bigger bleeding risks. So it's really back to standard thromboprophylaxis for the patients who've got COVID and who are on critical care, unless someone disagrees.
I absolutely agree. Can we maybe advance the slides? I think we have some of the trials and some of the slides that we had prepared. Can we go to the next slide, please? And our experience here has been similar. You know, in the beginning of the pandemic, we obviously saw exactly the same thing that you saw, as high numbers of fibrinogen, you know, incredibly frequent thromboses of vascular access catheters. I remember changing dialysis catheters within minutes of placing them and aspirating pure clot. And that was in the early phase. So maybe some of the phenotypes of the virus have changed, and certainly through the presentation with the early use of immunomodulators is less inflammatory. And so that concept of immunothrombosis may be changing as our treatment changes. We're using more steroids, we're maybe ventilating patients a little less aggressively in the early couple stages. But we haven't found the perfect biomarker. I mean, our protocol initially, we kind of, going again based on observational data, I leaned very heavily on D-dimers to decide on when to screen with point of care ultrasound for the presence of thrombosis, which we've never done in prior disease states. and then maybe escalate to intermediate dose. And now we are revisiting that practice because I think a guideline, at least a D-dimer-based approach has not panned out, whereas maybe in the future, IL-6, maybe other inflammatory markers for the guidance for anti-inflammatory drugs may be appropriate to identify a phenotype that's hyper-inflammatory. At least the D-dimer and the critical care population as an absolute number is not predictive. Certainly if it jumps from 2,000 to 15,000 and the patient is clinically deteriorating, that's maybe suggestive. But an absolute number, which we had hoped in the beginning and maybe tailored our strategy a little bit too aggressively towards anticoagulation, is not the biomarker that we should be looking for.
Indeed, and there was an early study out of Wuhan that looked back at the previous patients who had viral pneumonia and needed ventilating, and they too had very high levels of D-dimers. And actually it's a marker, I think, of acute respiratory distress syndrome. And we know that the lung can produce urokinase to break down the areas of fibrin. And I suspect that what we're seeing is flow of D-dimers coming from the lung and getting into the systemic circulation, because the D-dimer level, it does appear to be a marker of prognosis. And I think that's because it's coming from the lung, which is so inflamed that it's got a worse outcome. What do you think about that, Simon?
I think absolutely agree with that. It's a marker of severity of illness, and I think inflammation and thrombosis correlate with severity of illness as much as it correlates with anything else. I think it'd be curious to see how the different data pan out when you compare critically ill versus moderately ill. Those who are hospitalized but not critically ill seem to maybe not progress to severe disease if we're a little bit more aggressive with anticoagulation. I know a lot's been said about heparin and its inflammatory role and maybe in the lung. But again, how do we select that patient population that derives a benefit without the increased risk of bleeding?
Well, we've been giving it to all our moderately ill patients because the increased risk of bleeding is only slight, and we haven't had too many bleeding problems. I was intrigued to hear that Georg felt that there was more bleeding with this wave. It's not something I've seen. Has anybody else got that same feeling?
Not the most recent wave, the previous waves, I thought there was more bleeding than on the most recent one.
We did see that over here as well. I second that, George. So in July of 2020, we had a lot more bleeding complications during that peak. And this time around, for our last peak between July and September of 2021, we're seeing a lot more thrombosis. We're seeing a lot more arterial thrombosis, especially in the lower extremities, and not as much bleeding. And that, I believe, is one of the limitations of our studies, is that we are designing a study based on the previous phenotype. And by the time we study it, we're studying it on a different phenotype. So that affects the outcomes of some of our studies. I was curious to hear what the group thought about nebulized heparin in this group.
Sorry, can I just ask you a bit more about the different phenotype? Do you think the different phenotype is because the patients are different or because the virus is different? Because obviously we're seeing Delta in the UK. What are you saying?
It is both. So this phenotype is predominantly Delta, but it's also a much younger patient population. So the last phenotype was different for the virus and the patient population. So we're seeing a change in the type of patient and the virus versus this year and last year. So you're changing two variables there, which could have a tremendous impact on the immune response and immunomodulation.
And as far as nebulized heparin goes, I mean, heparin has got a theoretical antiviral effect in that it stoichiometrically blocks the virus binding to the ACE2 receptor. But I think that we're giving it too late, aren't we, by the time the patients have got to critical care? I mean, obviously we need to do the trials, and you can't predict what they're going to show, but you do wonder if giving it to people who are at high risk of getting severe COVID might be the way forward, but obviously we need to wait and see.
Agree. The bulk of the benefit is, I believe, to be gained in the moderately ill population before they make it to the ICU.
Can I ask another question? Be interested to hear your views in relation to you have anticoagulated a patient now who's moderately or severely ill on the ICU. I guess first-line treatment still be unfractionated heparin. How do you monitor? And what would the role be of antithrombin 3 levels, especially in the very sick, let's say, ECMO patient?
Okay, so I hate the use of unfractionated heparin intravenously. The patients are only in range as they are going up, out of range, or coming down out of range. It's an awful drug. You wouldn't license it this day because you are so dependent on your antithrombin levels, and also you're very much affected by the inflammatory state. So if you've got high factor VIII levels, as you have in patients with COVID, you'll probably end up giving more heparin than somebody who had a low factor VIII if you use the APTT. And I suspect that might be one of the reasons for the increased bleeding rates. So firstly, I'd much rather you use low molecular weight heparin, and you monitor with anti-10A, and you should monitor with anti-10A too, with unfractionated heparins. And it's just been a global, among the hematologists, it's been a global move towards getting anti-10A levels set up in all the hospitals, 24/7 access to get them for these patients. Measuring antithrombin levels, yes, it's an important thing, especially in ECMO, because the more heparin you use, you'll gradually deplete the antithrombin, and of course it's potentiating the antithrombin. The patient's probably a little bit malnourished, they've got a bit of liver disease, so they won't be making quite so much. So we monitor less than 60%, we'd consider giving antithrombin concentrates. Not everybody has the luxury of antithrombin concentrates, and you can just use fresh frozen plasma as a source of antithrombin in that setting. Yeah, it's the way forward, I think, for the critically ill on ECMO.
Is the practice the same elsewhere, or?
So I second that completely. I second that. I think unfractionated heparin, unless you have to, I would love to not use it. I think low molecular weight heparin, weight-based and adjusted for renal function, I think is part of our standard nomogram. Where we do find unfractionated heparin important is, I think, continuous renal replacement therapy, where you have clinical evidence of filter thrombosis, the addition of heparin into both the circuit, or then escalating doses based on the clinical gestalt or the need. It does prolong our circuit lives. And there's, I think, evolving data on that the circuit duration is much longer or less reduced. I'm not entirely a part of the ECMO circuit here. I think we know that initially in the early surges, we've used a lot of anticoagulation for ECMO, whereas for COVID-19 ARDS, or maybe escalating doses compared to the ARDS cases treated with ECMO in prior for other reasons. As the pandemic has moved on, I think we've reverted back to, I think, practicing good critical care. I think the ECMO team is experiencing now that if they do manage their circuits, how they have learned as a team with our local experience to manage the circuits, our outcomes are good. And I think that's one of the big highlights that we've taken away from the pandemic, is that above and beyond practice good critical care, and then integrate new data as it comes, if it is good data. I think that's probably the biggest value. And I'd probably just add back some of the bleeding that I think we may have seen in the early stages is because there was some vigilante escalation of anticoagulation in patients that may not have benefited and may have had risk that we didn't assess really in a systematic fashion. So I think a systematic application of good critical care is what we've taken away from, and that includes anticoagulation.
I would wish that Argatroban reduced its price so it could take over from unfractionated heparin. It's a wonderful drug. It works directly. You're not dependent on antithrombin levels. And once you reach a plateau, you stay there. It's wonderful. And it's got that same, when you stop it, it's all gone within 4 hours unless you've got really bad renal failure. So I wish the world could switch to argatroban. We all need to talk to the manufacturers and ask them to drop the price. They won't, will they?
There was a question around ACT as a monitoring tool, I guess for heparin therapy in patients on renal replacement therapy, as to whether or not the panel feels that is a reasonable thing to do.
Are you saying to measure antithrombin levels during hemodialysis? I'm not quite clear what the question. Are we in a COVID patient, but not routinely?
Let's say in a COVID patient on continuous renal replacement therapy.
Yes, I think so. I think it's, and yes, I would. Not outside COVID, but if somebody was sick in critical care, yes, they need monitoring.
Certainly. Could I ask you a question? Because obviously you've been essentially driving and chairing a lot of the committee for trials and the guidelines. So I think your view would be really appreciated here. So do you remember when we started in the COVID-19, the impression was that as the severity of disease increased, obviously the need for anticoagulation increased as well. And obviously trials have not shown that at all. And I just was wondering whether your thought was, is it because now the risk-benefit of bleeding versus anticoagulation is going in the favor of not giving anticoagulation, or you think the composition of the thrombus has changed? Because there are some data where you go from a platelet-rich to a net-rich, and whether that kind of thrombus is now no longer sort of sensitive to the anticoagulation and actually increases the worse outcome. Just wondering what your thoughts were on that.
Okay, I think that the trials have shown improved clinical outcome. They didn't particularly look at rates of VTE, and they're dropped, but they're not as dropped as they fall with good anticoagulation, but not so much as you might expect. And I think that the Brazilian trial where they used full dose rivaroxaban in sick patients showed no benefit at all, or in the moderate, and a huge bleeding rate. And so there is something about heparin, and I would say that heparin is aiding in the anti-inflammatory effect. That's some of its mechanism of action in the COVID patients, and maybe the antiviral. Be interested to hear from Simon what he thinks too.
I wish I knew more. I wish I could answer that. I feel this. I feel similar. I think the data seems to suggest that anticoagulation in the at-risk population may prevent progression. And then I would love to say we know exactly why or which part. I was recently talking to our colleagues of vascular medicine and hospital medicine of how to decide who to anticoagulate. And someone described the coagulopathy of COVID as a dumpster fire of endothelial activation. And I think as sad as it is, I don't think we can describe it any better from what we know now. We know that there's endothelial activation. We know that there's inflammation and thrombosis. Heparin probably plays a very important role. And if we can prevent both macro and microvascular thrombosis at an early point, we might prevent progression. By the time we are in the ICU in ARDS, some of that damage may have been done and the benefit may not be there. And it'll be interesting to see where the pathophysiology pans out on a specific level. platelets are involved, the endothelium is involved, the lung is very active, and we'll go from there.
I agree. It's a double whammy. We've got we look at Virchow's triad, we've got really sticky blood, there's very high fibrinogens and factor VIII and von Willebrand factor, so that we've got the inflammatory response probably coming from the lung, the very high IL-6 leading to increased production of coagulation factors, and then the endothelium being activated as well. What other disease does this? It's extraordinary. So yeah, I think which is the biggest player? It's hard to say, and it will vary between individuals, but you have to think about both of those aspects, really.
Thank you so much. I think we've had a lot of insight into the pragmatic management of anticoagulation and clotting in general associated with this disease. There was a question which came through around factor Xa monitoring, and I think we've answered the question. That is really the way forward, and everybody now is routinely, increasingly doing that. I thank you so much for making the time and joining us. We could probably discuss for another hour easily, but it's a great pleasure now for me to move on, introduce the next session and the next speakers. So the next session will be chaired by Hassan Cooley, who's already been joining us previously. He works at Cleveland Clinic in Ohio and is department chair for critical care medicine. And I also welcome Sam Patel, who's my colleague and friend, who works with me at King's and will be joining us here at Cleveland Clinic London as well. So the title of the session, I should have said, is COVID Clinical Data. Hassan and Sam.
Thank you very much, George. Can you hear me?
Yes.
Great. Sam and I are really appreciative of the opportunity to join this conference, this symposium, and it's a fantastic discussions that we just left off, and I know our team here is gonna as well is going to actually share with you a lot of data on a very timely topic, you know, I would say, and has been going on, although it's quite challenging. I think many of us at the start of the pandemic, when you look at clinical data, we have been bombarded by all kind of publications, data coming from everywhere, different stages during the pandemic, and some of it structured, some of it may be vetted, some of it is not, and we had to manage this and react to it as we continue to manage patients with, with COVID. So our panel, our speakers are going to share with us what they have learned from this data, and talk about some of the characteristics and phenotyping in this. And I hand it over to my colleague and partner Sam to take on the introduction for the next two sessions. Thank you, Sam.
Thank you, Hassan. It's a great pleasure to be here, and thank you, George, and to the Cleveland Clinic community for inviting me to be part of this. It's a very exciting day so far, and I think, as Hassan's already said, this is going to be a fantastic session and nicely complements the previous sessions that we've had so far. So moving on, I'd like to introduce my colleague and friend, Dr. Luigi Camprota from Guy's and St. Thomas's. He is a consultant intensivist with a specialist interest in severe acute respiratory failure, mechanical ventilation, and is the clinical lead for ECMO at St. Thomas's. And he is going to be talking on characteristics of COVID-19 and ARDS. Thank you, Luigi. Luigi, you're on mute, unfortunately.
I was just thanking you for the lovely introduction, thanking also Sam for co-chairing this session. I'm really grateful to be here today. So I would like to start with one idea. Essentially what we know is that COVID-19 is a mainly respiratory disease. and the main characteristic is hypoxemia. But I would like to draw attention to some of the differences which are characteristic of the COVID-19. So when we look at the ARDS there on the left-hand side, we know two things. One is that as the lung edema increases and the quantity of non-aerated lung tissue increases, the hypoxemia becomes more severe. To the point there is almost a linear relationship between the PF ratio and the quantity of non-aerated lung tissue. And that has been called anatomical shunt. And that has been demonstrated many, many times in postoperative care, in ARDS, and therefore that's been the classical mechanism by which we can quantify anatomical shunt. So CT scan is equal to PF ratio. Next, please, Maria. COVID-19 makes things more complicated, but also more interesting in a way that we've heard a lot about how the COVID-19 virus, so the SARS-CoV-2, alters the angiotensin metabolism, causes inflammation. So now when we look at the mechanism of hypoxemia, we've got on the right-hand side the usual inflammatory edema that causes consolidation and so an ARDS-like pathology. But when we did some modeling and you look at the quantity of the PF ratio, so the degree of hypoxemia that you would expect given the degree of consolidation, we found that essentially the amount of hypoxemia was far superior to what you could expect by the consolidation. And that is because there's mainly a problem with pulmonary perfusion. There is excessive perfusion due to neoangiogenesis, vascular abnormalities, and also some perfusion defects. And we've heard a lot about the immunothrombosis that can affect gas exchange. Next, please. So then we've got this fantastic series of studies, and I'm showing you one just because we've got only 5 minutes. But what you can see here, this is an iodine map. And what you can see is the distribution of perfusion in areas of different level of ventilation. So what you can see, first of all, is that the lung is mainly maintained in terms of gas volume. But if you can go next, please, Maria. You can see that in purple, you can see that some of the areas that are normally ventilated, they are severely hypoperfused. And if you go next, please, you can see that some of the areas that actually have got ground glass and less ventilated, they've got increased perfusion. So now, if we know that increased perfusion and low ventilation means shunt or venous admixture that goes into the hypoxemia, and the hypoperfusion of normally ventilated lung gives you dead space. And in one slide, you can see the main issue. You see maintained lung volume, but severe VQ mismatch. And that has been associated with an increase in ICU admission and invasive mechanical ventilation. Please, next. And this is what has led this concept, that in a way, COVID ARDS, particularly at the beginning, is very different from typical ARDS. And this is one of the studies that we've done with Davide Chiumella and Luciano Gattinoni. You can see there that when we compared COVID ARDS with ARDS from other causes, you can see that COVID ARDS had a more severe PF ratio when the compliance was the same. And likewise, they had a much better compliance when they were matched for PF ratio. Next, please. And so this is just a graph that shows on the left-hand side, you can see ARDS patients matched for PF ratio. And on the right-hand side, you can see ARDS patients matched for compliance. What you can see very clearly is that the degree of shunt fraction or venous admixture is proportionally related to the non-aerated tissue fraction. So essentially the amount of consolidation. That's not the case with COVID ARDS. You can see there is no relationship between non-aerated lung tissue and venous admixture. So that creates a problem because we can see later on tomorrow how this might change the level of ventilation and the degree of pressure of respiratory support that we can give to these patients. Next, please. And in a way, this has led to this concept. There are two temporal phenotypes with the same degree of hypoxemia. You can see these are two patients. One, they've got the same PF ratio, 95 and 84, which puts them in the severe category of ARDS. But one at the top, you would agree that the lung volume is completely preserved, and you wouldn't expect that degree of severity of gas exchange, whereas the other one is more similar to the typical ARDS, and we call those phenotypes type L and type H, and you can see next, please, Maria. And with that, I would like to thank you for your attention, but just I wanted to show you how with the same degree of hypoxemia, we've got very different characteristics that they should inform us the way we treat these patients at the bedside, and we can go into it much more later on and certainly tomorrow. Thank you.
Thank you, Luigi, for a great talk. If you don't mind, we'll take all the questions at the end of the session so that we can fill them all together. So I'd like to just move on and introduce Dr. Jihad Malat. He's a staff physician in the Critical Care Institute at Cleveland Clinic, Abu Dhabi, and has a specialist interest in circulatory failure and its management, heart-lung interactions, and ventilation. And Dr. Malat will be talking about stratification and outcome of COVID-19 ARDS. So thank you, Jihad.
Thank you, Sam, for this lovely introduction, and I'm very happy to be with you here today. So I'm going to start, next slide, please, with the characteristics, patient characteristics and outcome. Around 4,000 COVID-19 patients who were admitted to intensive care unit in Italy were included in this retrospective study. The hospital mortality rate was around 27%, and you can see in table 2, age was independently associated with mortality in the multivariable analysis, along with gender and some comorbidities such as type 2 diabetes and COPD. On the right side, you can see that the Kaplan-Meier analysis shows that the patient aged more than 64 years old had a lower survival probability rate compared to patient aged less than 64 years. Next slide, please. And this is a prospective multi-center study that was conducted in 138 hospitals in France, Belgium, and Switzerland. The 90-day mortality rate was around 30%, and the authors found also that age was independently associated with mortality, along with immunodeficiency, body mass index, and diabetes. Next slide, please. So now what about inflammatory state and outcome in this meta-analysis that included more than 6,000 patients? You can see that the procalcitonin, that C-reactive protein, interleukin-6, interleukin-10, the dimer were all significantly higher in patients who had the severe COVID-19 disease compared to mild COVID-19 disease. Next. And we can see also that these inflammatory markers were also significantly higher in patients who died compared to patients who survived. Next. And in this retrospective study that included also 140 patients, you can see that interleukin-6 level, CRP, and procalcitonin on hospital admission were all significantly higher in severe COVID-19 disease compared to mild disease, and elevated interleukin-6, CRP, and procalcitonin were also associated with a lower survival rate. Next. So now what about the relationship between the severity of COVID-19 disease and the outcome? You can see in this REVA study that severe ARDS was associated with lower survival rate compared to mild and moderate ARDS, and table 4, the need for vasopressor or the development of acute renal failure were also independently associated with higher mortality. Next. Now, what about the respiratory support and the relationship with outcome? You can see that in the REBA study, the patient who died, the use of invasive mechanical ventilation was significantly higher, 75% compared to 58% in the survival group. On the contrary, high flow oxygen rate was higher in the survival group compared to death group. And in the Lombardi study, the use of invasive mechanical ventilation was independently associated with higher mortality compared to non-invasive ventilation. Next, please. So now, what about the intensity of mechanical ventilation and outcome? And this PREVENT COVID study that included more than 800 COVID-19 patients with invasive mechanical ventilation. The author found that driving pressure at baseline was not associated with mortality. However, mechanical power, high mechanical power more than 17 was associated with lower survival rate compared to mechanical power was less than 17. Next, please. And in this COVID-19 went to ICU study that included around 240 COVID-19 patients with invasive mechanical ventilation, you can see that respiratory static compliance was associated with mortality in a non-linear way, figure A. And you can see that lower compliance was associated with higher ICU mortality. And in the figure B, driving pressure was associated with ICU mortality in a linear way. However, tidal volume was not found to be associated with mortality. And in table 2, when they did multivariable analysis after adjusting for potential confounders such as age, SOFA score at ICU admission, Charleston score, PF ratio, etc., you can see that respiratory compliance and driving pressure were still independently associated with mortality rate. Next slide, please. And as you can see, the need for ECMO is associated with high mortality. You can see that in this study, hospital survival was less than 50%, and it's actually worse in the second wave compared to the first wave. So to summarize, age, comorbidities, high inflammatory, hyperinflammatory state, invasive mechanical ventilation, low respiratory compliance, high driving pressure were all associated with bad outcomes. Thank you so much.
Thank you very much, Luigi and Jihad, for your presentations and for staying on time as well. We'll move on with our next session here. The title is Patient Phenotypes during the first, second, third, and in some places fourth and fifth wave rounds. It's a roundtable discussion actually by 3 of our speakers here that I'll introduce them from different places. This global conference, they're represented very well. Georg Chaudhry is one of our critical care staff in Ohio, and he's the Associate Director for ICU Operations at the Cleveland Clinic and the Director for the East Region Critical Care in the Department of Critical Care Medicine. Gabor Zilahi too is joining us, and Gabor is a cardiac anesthesiologist and consultant intensivist at St. George Hospital, London, and soon I understand to join the Cleveland Clinic London too, with a special interest in ICU echocardiography and ultrasound. And then we'll be joined by Vivek Kakar, who's a former consultant at the King's College Hospital before he actually now moved not too far to Cleveland Clinic Abu Dhabi, and then he's a section head for in the Critical Care Institute there with a special interest in cardiopulmonary critical care and ECMO there. So Georg is going to start us off talking about phenotypes and operational data. Please go ahead, Georg.
Yeah, perfect. No, thank you. Good afternoon. Thank you for allowing me the opportunity to present. Again, my expertise is in pulmonary critical care, and I really focus more on sepsis and ICU operations. So you'll see that interest in my presentation. Next slide, please. So these first two slides that I'm going to present really are looking at phenotypes and subphenotypes of patients with COVID-19. And these are all patients who had a positive test, RT-PCR test, done in the Cleveland Clinic Health System in Ohio or Florida. The duration is from March, I believe it's March 12th, 2020, all the way through October 2020, and only adult patients, so the ones 18 years and above. So the total number of tests that came back positive were close to 20,000. What they did was actually split all the positive tests into a training set and a testing set. So the training test set had about 11,800 positive cases, and the testing set had about 9,000 cases. And then I'm going to talk about the subphenotypes, which were the number of patients that were hospitalized. So the first one, for all the positive tests from the test data, they were able to come up with 7 phenotypes and predicting what their risk for hospitalization are going to be. So the first was young patients. And when I say young, it means 33 to 34 years of age was the median age group, separating them into no symptoms versus patients with symptoms, and the rate of hospitalization was 10%. Talking about middle-aged with symptoms, no symptoms, and then with comorbidities, and these comorbidities are the usual trifecta of COPD, emphysema, diabetes, hypertension, maybe with some cancer thrown in. And as you can see, this median age group is 56 to 60 years, and risk of hospitalization of 22%, 33%, and then 24%. And then the older age group, which is 75 years, around median age of 75 years, no symptoms or with symptoms. And as you see, no symptoms, your risk of hospitalization was 47%, but if you're old, closer to 75 with symptoms, the risk of hospitalization of 59%. Next slide, please. So my first slide talked about the phenotypes, that if you had a positive test, what was your risk of being admitted if you had a positive test either in Ohio or in Florida. Now, these are the subphenotypes. These are the ones that you have been admitted. So out of the first 11,800 patients that were the test, which were the training set, 2,600 patients got admitted. And out of the 9,000 patients that were the testing set, 900 patients got admitted. Out of those, in these subphenotypes, if you were young but had an elevated white count, the risk of transfer to the ICU was 12%, but you had a 0% mortality. If you're middle-aged again, so between 50 to 60, if you're lymphopenic with an elevated CRP, you had a risk of transfer to ICU was 12% with close to 3% mortality. What really stuck out to me was this middle-aged with a hyperinflammatory subphenotype, which had a 50% risk of transfer to ICU or death, and I'll talk more about this. And then older, which is close to 75, leukopenic with comorbidities, risk of transfer to ICU mortality was 32%, hyperinflammatory was close to 60%. Now, this is looking at a composite endpoint of transfer to ICU or mortality in the middle age group, which was 50%. But if you separate that and only look at ICU mortality, then it's the middle-aged hyperinflammatory risk of mortality is actually lower much lower than the 50% predicted. It's lower than the patients who are older, leukopenic with comorbidities. Next slide, please. So looking at operational data, looking at as to how many waves we have had so far in Ohio. So this is Ohio only. This does not include Florida. You can see the fifth wave, which is currently ongoing, is really well described. The first, second, third was our highest, then fourth and fifth, with a total of 16,200 admissions so far in the state of Ohio in our Cleveland Clinic system. Next slide, please. Looking at demographics, all of this data is from our business intelligence group that helps analyze and helps predict as to what our bed capacity needs is going to be. So looking at demographics, looking at race first, really no big standouts here. I think it's very representative of the population that we're serving. We did have more white patients, who identified as white as compared to black, and this has remained pretty standard throughout all 5 waves of this pandemic. Next slide, please. When it comes to gender, I've tried to squint at this slide many times and trying to find a difference, whether it was more males versus females, but it seems like it's a pretty even split between males and females. I don't know how the rest of the panelists feel, but I feel like the men generally don't survive, but the wives always tend to go home. Next slide, please. And then this, I think, was the most interesting slide, really looking at the ages. And I have this blue arrow pointing to where the flip happened. And the flip happens exactly in the end of March, end of February, early March. So this has been a couple of months into the whole vaccination program. And you see that the patients who are 75 and above with the high vaccination rates actually have a lower risk of hospitalization. And you see this slow creep up of the 35 to 54-year-old age group. So, the really clear demonstration of the fact that vaccines do work. And final slide, please. So key takeaways, as we've heard so far, the hyperinflammatory phenotype is a bad prognostic sign, especially patients who have a hyperinflammatory phenotype and kidney dysfunction. We are currently in our wave number 5 and clear demonstration of the vaccine effect with improvement in hospitalization rates for patients above the age of 75. Thank you.
Thank you very much. First of all, my name is Gabor, and thank you for the kind invitation. It's a privilege to be here and talk about the UK data, and maybe just allude some of the phenotypes. I work in St. George's Hospital at the moment, but I'm going to join Cleveland Clinic in January. Next slide, please. So before I go into the data, I just need to highlight what happened in the UK. As you can see on the left-hand side, we had already 2 waves. The second one had 2 bumps. The first wave was mainly by the alpha variant, and as you can see, if we go into the second wave, it started with the alpha variant but changed into the beta variant very rapidly and caused a significant issue with huge ICU admission rate. What I'm talking about here is an ICNIVE data set, which is the National Audit for Intensive Care. It's a very rich data set. As you can see, we have 36,000 ICU admissions across England, Wales, and Northern Ireland. In this data set, 10,000 coming from the first wave and 26,000 coming from the second wave. And the third wave is happening now. I don't have enough data to present that, so I'm going to leave it for the next Cleveland Clinic meeting. I hope there will be more. Next slide, please. Before I talk about the data, we need to understand that it can be biased, and we talked about this quite detailed in the morning, that the bed situation in the United Kingdom is surprisingly different than in Europe. If you look at the left-hand side of the screen, this is the ICU bed per 100,000 inhabitants, and the one in the bracket is the United Kingdom, which is 6 around 2012. It went up to 7 around 2018. But if you look at the average on the bottom, which is the green slide, it's way beyond the average across Europe. And if you look at Germany, they have 30 beds per 100,000 capita. And if you look at the middle of the screen, that obviously is biasing the data, because during the first peak around April 2020, we started to probably unconsciously select patients. As you can see, the elderly patients did not get into intensive care, as the patient with prior dependency had a lower portion. This is all COVID patients on the data. And of course, when you put the system under stress, it has its own problems. If you look at the right side of the slide, there's a very honest article. I urge you to read it, which highlights the fact that across England, the NHS Trust have had vastly different outcomes with COVID-19 patients, going from hazard ratio to 0 up to 2.5 or even more. So even just being in the wrong hospital in England created a worst outcome for your patient. Next slide, please. This is the data set from ICNAC. It's a busy slide. I'm sorry for this, but I'm going to explain. In the middle of the screen where the hazard is admitted up to 31st of August, that's the first wave with 10,000 patients. Next to it, on the left-hand side, admitted from September, that's September 2020, that's the second wave with 26,000 patients in it. As you can see, the median age didn't really change, it's 60-60. The male-female ratio in the UK was 30-70%. Maybe it's something to do with the demographics. We can talk about that later. These are ICU patients, and most of our patients in the intensive care, 90% of them, were able to live without any assistant in their daily activities. It's a highly selected patient population. If you look at the right side of the screen with the bars, the first one on the top, where the orange dots represent the population average, so what you expect. The first columns show you the deprivated state. So as you expect, you should have an evenly distributed patient population in your intensive care, regardless of their deprivation. But it wasn't true with COVID, of course. As you can see, in category 4 and 5 were overrepresented, so the poorest came to intensive care. It's the same with the high BMI patients. This is not surprising. That has been shown already in this meeting, and we know all that. The BMI more than 40 is a risk factor to end up in intensive care with this COVID. In the UK, the white population, that's the third column, were underrepresented. It's probably something to do with the way we adhere to isolation and probably with deprivation. But the BAME group, the Black, the Asian, and the other minority group were overrepresented. And not surprisingly, on the lowest column, you can see the age distribution, where the blue column is the male, the gray column is the female. And as you can see, if you compare it to the orange dots, which I said is the population expected data, the male over 50 population is super represented in this disease. If you look at the left-hand side on the top of this line, you can see that there are some differences between the two waves, and I just highlighted some of them. There are a lot of differences actually, but in terms of demographics, we started to see even more patients with high BMI. It goes from 8 to 12%. The white population is increasing, again, something to do probably with the lockdown and the way we adhere to it. And we started to see pregnant women and women with recent pregnancy. The numbers are increasing, which is quite frightening. Next slide, please. And of course, the data is changing. The patient behavior is changing because the way we treat them is changing. As you can see, between the two humps, between the two surges, we had the recovery trial announced, and we started to use steroid, at least started to use it officially. I'm sure some of the UK hospitals used it beforehand, but in my trust, we wanted to adhere to evidence-based, and we didn't use it, and we started to use it, and the way they behaved was vastly different. And of course, in the middle of the second surge, you see the REMAP Cup was preliminarily announced, and we started to use IL-6 inhibitors, tocilizumab, and at the same time, we started our vaccination program, which at the beginning of the third wave, as you can see, is quite advanced. The first vaccine has been 80% across the adult population in the UK, and at this date, it's the second dose is close to 80%, and I just had my third dose this morning, so I'm very happy. Next slide. Now, as I said, we believe that we learned the disease and we started new therapies, but the outcome is quite disappointing still. As you can see on the left-hand side, this is a 28-day outcome between the first and the second wave. And the 28-day outcome is a bit better with the second wave, but quite disappointingly, if you look at the right-hand side, the 90-day outcome is more or less the same between the two groups. Now, not all of the data in this study has been analyzed at that stage. Next slide. And what has changed? Many things changed between the two groups. Again, in the middle of the screen, admitted up to 31st of August, that's the first wave. And next to it on the left-hand side, that's the second wave. We talked about the mortality, but let's see what we changed. So our approach to them was different. 72% of the patients in the first wave were intubated, which went down to 55%. And we learned that we don't necessarily need to intubate them just because they're hypoxemic. And the basic respiratory support, of course, at the same time increased, but that really didn't change the outcome, especially in the CPAP and IV group. So that's very interesting. With starting immunosuppression and immunomodulation, the need for advanced cardiovascular support and the need for renal replacement support changed significantly. If you look at the middle of the slide, it goes from 30% to 20%, and the need for renal replacement therapy went from 25% to 16%. And it's not because the patient population vastly changes. I think it's the way we treated them. If you look at the right-hand side of the screen, on the top, you see the approaches we had in terms of early intubation. And we started to drop our early intubation even after the first peak, although their PF ratio didn't really change. We just started to accept that they're hypoxemic. And there's a lot of data in this. So it's open. It can be searched on the ICNAG database, and I urge you to read it. It's very rich, very important. And I stop here because I only have 5 minutes for this, but very happy to take questions. Thank you very much.
Thank you, Gabor. I think we can move. Yeah.
Hello, everyone. This is Vivek here. I work at Clinic Abu Dhabi. Many thanks, Hassan and Sam, for the kind introduction. I believe you've been shown data from all over the world, and although I don't have the UAE data abstracted in any form to share with you, but I'd like to give you a brief overview of the data from Clinic Abu Dhabi, and hopefully you get a glimpse of what was here. Before I go ahead, I think it's worth highlighting just a few things. I don't need to tell you where UAE is, but it's a small country of 10 million people, of which, interestingly, 90% are expatriates, majority from the Indian subcontinent, the Philippines, as well as the GCC nations. And next, please. Yeah, next. Yes. Next, our cohort, given that you would expect from a population that is migrant for active employed, so the age group is also relatively younger for overall. And although we have a substantial expat population, majority of them are the lower strata who have a poor awareness and control of their comorbidities. And while the healthcare in the UAE is public-private mix and the healthcare insurance is mandatory, during the COVID, the government actually made all COVID-related health matters available freely to everyone, regardless of their insurance status, including quaternary services. Next. Next, please. And speaking of Cleveland Clinic Abu Dhabi, we are the only public health facility for cardiac surgery, stroke, and ECMO. And so we serve the sickest patients during the COVID, Center of Excellence, ECMO, and those who spilled over from other centers during the peak when they were out of capacity. Next. So I think this is just to highlight that our denominator is very unique, even, compared to the rest of the world. Next slide, please. Next slide, please. So the UAE, even though you see minor surges, as such, we experienced two major waves actually from January until the end of October, beginning of November last year, and the second wave that started in January this year and is just about tailing off now. Next, please. And compared to the global case fatality rate in UAE, next, please keep clicking. Compared to the global average case fatality rate, the UAE saw around 725,000 cases. Next, please. Next. Our case fatality rate overall in the UAE, next, was only 0.28%. However, given our case mix at the Cleveland Clinic Abu Dhabi, the case fatality rate was higher, 3.6%. Next. And the next slide, please. Next slide, please. Yeah. The part of the reason why the UAE had one of the lowest overall cases as well per million, as well as the case fatality rate, was also next, please. But also because the early and proactive adoption of some of the practices that world over were later on also practiced. Next, please. Next. And this included, a very exhaustive COVID testing, a vigorous immunization drive. Next. 90%, more than 90% of the population has had at least one dose, and 80%, just over 80% actually. Next, about 80% of the population has received both doses of COVID vaccine. Next. Okay. Now, speaking about the demographic, you would see that comparing the two waves, our second wave had patients that were comparatively older, had a higher proportion of female patients, and a much higher proportion of the native Emirati population. And although overall there was a significant incidence of comorbidities in this patient, the second wave had even higher incidence of diabetes, hypertension, obesity, something that has also been highlighted by, I think, Gabor in his presentation, but also history of coronary artery disease and prior stroke. Next. Okay. In addition, actually, as I said, we saw, a fair amount of patients with septic shock, which is probably not atypical of this population, but we also had a similar incidence of cardiogenic shock, ST elevation MI, and pulmonary embolism in the two populations. But a quarter of the patients in the first wave and a third of the patients in the second wave had acute stroke, which is in keeping with what I mentioned about our center. Next slide, please. Our choice of therapies reflects the evolving paradigm in management of COVID, and I think overall you can see the range of therapies that we use. Next slide, please. But comparing the two waves, next slide. Yeah, comparing the two waves, it's not surprising that we used higher remdesivir and steroids in the second wave compared to the first wave, and none of the agents that we used in the first wave. We also, if you notice, use less tocilizumab in the second wave, which is partly, I think, some patients were transferred to us late and already had received, but also we use far more interleukin-6 monitoring that is generally reported, and I didn't rely much on CRP for decision making regarding tocilizumab administration. Next slide, please. Looking then at the outcomes comparing the two waves, a little over the third of all patients that we received were admitted to ICU, and half of them were ventilated, which is not different between the two waves. For some reason, we did prone less in our second wave. 10% of our patients in the second wave were ECMO patients, despite the higher comorbidities, older age, and higher ECMO proportion. Our mortality in the second wave was much lower than the first wave. Now, sadly, I don't have the data on inflammatory markers, which we have collected a lot actually, but we just haven't had the chance to extract it and compare it between the waves. But we can say from personal experience, and Jihad is also online, that we did see lower inflammatory or lesser inflammatory profile in the second wave. Overall, the length of stay actually for the vented patients was higher, and I think that's probably because of the ECMO patients who consistently had a higher, longer ICU length of stay. But overall, the hospital length of stay was similar between the two groups. I think that's all from me.
Thank you very much, Chirag, Gabor, and Vivek for sharing your perspectives and local data. George, do we have any time for questions? I know we're a few minutes over.
I think we've got time for a couple of questions. Yes, Hassan, thank you.
Thank you. So I'll start with the first question, and Luigi, maybe you can take a stab at this one, and others can weigh in on this. What do you see the role of the chest CT scan in characterizing patients with ARDS with COVID-19 and in managing patients as well? How has that really evolved in your clinical practice?
Thank you very much. I think it's a very important question. I mean, we realize that obviously doing CT scan is quite time consuming and resource intensive, and therefore particularly during the first wave maybe the use of CT scan was less, but we've done it routinely, and I think we found it useful in three ways. So one is obviously we discovered a large proportion of patients with pulmonary emboli. For example, about 35% of our patients had pulmonary emboli, which obviously tell us something about the etiology of the severe hypoxemia. So we treat those patients differently. So in a way, diagnostic, the level of anticoagulation that we've talked about. The second element is the degree of lung volume and the consolidation that sometimes is not really apparent on chest X-ray. And that has been helpful as well. And the third one is identification of patients with certain CT characteristics, for example, organizing pneumonia, for example, which has allowed us to go with a different treatment option, particularly in terms of dosage and duration of steroids. So I think these three elements have been very, very helpful, particularly for us. I don't know what other people think about it.
Thank you, Luigi. What do other people think about the 35% rate of incidence of pulmonary embolism? How is that experience in the other centers?
So I truly don't know as to what our actual rate is. I know we're not very aggressive about getting CT scans on our patients unless it's absolutely necessary. So we've really been tracking this D-dimer level and then doing a sequential DVT study followed by that. And then if there is suggestion of either sluggish flow or clot on the DVT, we just go ahead and anticoagulate the patient. So to really try and minimize transport, and it really, I think it's a dissatisfaction, especially a dissatisfier for our nurses when they have to move these patients down to a chest CT scanner.
We moved from not doing CT scans in the first wave to doing CT scans as a routine for every patient coming to intensive care unit. Interestingly, for two reasons, well, three reasons, and two of them Luigi just mentioned. First of all, to identify the PEs. Secondly, to somewhat grade the disease. But thirdly, we tend to do a day 7, day 10 CT scan as well to follow disease progression, because some of them don't respond to immunomodulation and steroid treatment. And in our institute, in that case, we sit down with a lung MDT and discuss whether further high-dose steroid treatment would be beneficial to tackle the organizing pneumonia or the early fibrotic stage. And for that, we need repeated CT scans to see the disease progression.
Thank you.
I wonder whether I might add one more thing. So we have been always with a high percentage of patients have been intubated. And so maybe that also facilitates a higher sort of proportion of patients going through CT scans, because I can see that if you're using lots of non-invasive support, particularly patients with higher FiO2, there might be more reluctance to have patients with CT scan with those modalities for obvious reasons. So yeah.
Yeah, that's interesting. When you look for the PE, certainly for the clots, you can find more of them there. What's the clinical significance of it? Is same thing with the lower extremities surveillance ultrasound for DVTs to there.
Thank you. Sorry, Luigi. No, you carry on.
We were just saying that sometimes the two DVT and PEs are dissociated, and in a way is what Beverly was saying earlier on, is an in situ pulmonary thrombosis from the high inflammation in the lung. And the other thing, we found no correlation with D-dimers and no correlation between D-dimers and dead space ventilation, D-dimers and the prevalence of PE. So they seem to be slightly different mechanisms.
Thank you.
Great. I just wondered if I could just ask one question, if I may, just to finish off the session. I think it was a fantastic session where we got to, which encapsulated the variation in phenotypes between waves, but also between regions around the world. I guess a question for bedside clinician, you know, a lot of information has come out from all of this, and a lot has changed over the last 18, 19 months. I guess a question for the panel is, how do you incorporate all the learning that has been made from both identifying phenotypes and then tailoring management accordingly to best inform management at the bedside? Because that's what it's all about, is just trying to get the best management. So just an open question for the panel, just to see what your thoughts are in how you know, factor all of this in to then best serve your patients.
So I can take a stab at that. I think one is that it will become, I don't know, I have a feeling it's probably going to be true for the group, is we've all become a lot more patient taking care of these patients. In critical care, we like things to like move quickly. We realize that things here don't move quickly. Sometimes that you just need to give it time. So that was a change in mindset. Also this change from allowing people on these really high amounts of high flow nasal cannula and not going in and intubating them. You know, Gabor, the data that he shared is very, you know, it's very, it reveals as to what the change in clinical pattern has been. So I think those were the two really two big changes over all these waves.
I only add one more thing. I think highlighted to me the importance of getting local data. And I think we've been very proactive in trying to accumulate data from the ward, from the ICU, from the high dependency unit on a daily basis and report it back. So basically you can see who we're treating, how they're responding, you can adapt, because we've seen such a huge variation worldwide and not necessarily might apply at your local level. So you can learn from others, but you need to look at your own case mix.
I think we need to draw this session to a close. I thank the chair and the co-chair and the panelists for a really interesting session yet again. We are almost at the end and we're only running about 15 minutes late, which I think is a big achievement given the number of excellent talks we have had. So this last session is a round table discussion around mechanical ventilation in COVID-19, data from smaller cohort studies, big data and epidemiological data, and how it helps us in managing these patients. I think we've got a great panel of experts in the world of ARDS and epidemiology from London, Ohio, Florida, and Abu Dhabi yet again. So I'll open this session for a roundtable discussion, and I've got Luigi sitting next to me, so maybe he wants to make a start.
Yes, thank you, George. And if you can, sorry, mate, you can go back. I would just like to say that very privileged to be part of this roundtable. Obviously, around this virtual table, we've got Abby Dugal, who's from Cleveland, Ohio, Edward Noguera, who's from Cleveland, Florida, and I don't know whether we've got Nadim, but if he managed to join, is from Abu Dhabi. And I would like to ask Abby to start, please, with the first slide. Thanks, Marie. Next, I think you might be muted, Abby.
So please bear with us while we are trying to sort out the audio. We can hear you now, yes.
Oh, perfect. Thanks, Luigi. So like this should be an interesting discussion. Looking forward to hearing everyone else's thoughts. So I wanted to talk about the fact that, you know, variability in outcomes associated with pandemics, especially in critically ill populations, is not a unique thing. So this is a meta-analysis and meta-regression that we had done when the H1N1 pandemic had come out. And it really shows that when you decide to report on outcomes in a pandemic, compared to where you're reporting those pandemics and what kind of populations you're going to be reporting on, has a huge impact on the reported mortality that will be listed in those populations. So when H1N1 came out, there was a significant difference in the reported mortality for wave 1 compared to wave 2. And then when we look at like where these studies really came out from, there was a very significant variation in their mortality reports. Also of importance is that the number of patients in any given study has a huge bearing on both the reported outcomes and the variation in terms of what exactly is seen. So very small studies have this tendency to over-report outcomes. Next slide, Luigi. Also, one thing that we have to be very, very mindful of whenever we look at observational studies in especially pandemics is what is the kind of population that we're talking about. So studies that looked at unselected critically ill patients compared to patients who were all mechanically ventilated, or let's say patients who were all presenting with ARDS or acute kidney injury, had significant variation in how, like, we would report the outcomes on those patients. And especially early on in the pandemic, it becomes a very important factor for us to think about as we read those initial reports and really kind of think about what the impact of those would be on our clinical practice. Next.
Thanks, Abby. I'm just going to take that data that you've very clearly illustrated for a non-COVID patients and bring it back to the COVID. This is data from my own hospital. And basically what you can see here is 3 cohorts of patients. You can see the sort of lighter purple, almost pink, which are the died patients who died, the one who was discharged alive, and the darker one is the one who's still in ICU. Now, you can see there for 3 black lines, because it depends based on the timing of the pandemic. And you can see very clearly that early reporting, so the first black line on your left, will give you almost a 50% mortality rate. But as you go on during the pandemic, you can see how the mortality changes and the percentage of mortality decreases over time. So that can explain a little bit about some of the variation in reporting over time with the pandemic. If I can have the next one, please. And Abby, you're going to talk about more about sleep.
This slide really just complements what Luigi just talked about. This is our data from Northeastern Ohio. And then we really saw the same thing, like where exactly we were in the pandemic early on really impacted how we reported both mortality and hospital-based outcomes. Where early on when we looked at the COVID patients, there was definitely a higher signal towards perhaps a higher mortality and higher rates of hospitalizations. But as we kind of moved forward with subsequent months, the numbers became very, very similar to what we usually see in all our ICU patients. Which I think is a very telling statistic in terms of what exactly Luigi alluded to. So I think here we wanted to just talk about briefly why it's important for us to think about data the right way whenever it comes out to any kind of epidemiological studies or observational research in general. This is a slide that I borrowed from Rob Fowler at University of Toronto. I love this slide because I think this really talks about the key factors that we need to think about. Next. I think the first thing to always be mindful of in these populations as you think about it is the selection bias, which is based on what kind of population we are really looking at. And we need to be mindful of, is there any bias that is really percolating before we make any assertions? Next. The other big thing is confounding. And if we don't think about confounding, we won't really address confounding. And then as clinicians, sometimes we really look at a cause and effect without really attributing what exactly the other factors are playing into when we think about outcomes. Next. One more, please, Luigi. And I think the other big thing that we have to always think about is the survivor treatment bias or the immortal time bias and confounding by indication. Because a lot of times as these disease processes go on, there's the aspect of time. And what we introduce in terms of therapies or don't introduce in terms of therapies has huge implications on what exactly the outcomes for those patients would be. Next. And I think, and one more, Luigi, thank you. And I think the only other factors that I always think about as I think about outcomes, especially when we're looking at critically ill patients, is effect modification. That will be a big factor in terms of the reported outcomes, and having an understanding of what time-dependent factors are and how they would have an impact on what we report in our outcomes. I think these are common pitfalls if we don't think about. We will look at outcomes erroneously in every kind of observational research. Luigi?
Thanks, Abby. If you go next, Maria, please. So I think I found this a very interesting diagram. I think this is from Doherty in the Lancet Respiratory Medicine. If you look at the causal relationship, when you can see all the mortality being the outcome and all the mediating factors, you can see on your left-hand side, there are some individual patient factors. And on the right-hand side, there are other things that are normally not very clearly reported, which is the very relevant in the pandemic, which is, for example, a critical care facility or the availability of it, and the other compounds that are present over there. So if you go next, Maria, please, we can see some of the effects. Now this is from the UK, and you can see how on the top left, you can see 28 days in hospital mortality, and you can see how the mortality has changed based on the number of patients currently in critical care at that time. So you can see how the mortality goes down as the occupancy rate or the strain in critical care goes down. Now you can see also on the right-hand side, those are the hazard ratio of mortality, and essentially show exactly the same thing. Whether you look at a percentage or hazard ratio, fully corrected for other parameters, it still goes down over time. And you can see at the time of the recovery trial, where the arrow is placed, the first arrow, you can see that already the 28 days mortality has started to decrease. So there is a clear element between strain and mortality. If you go next, please. This is again from the UK, and you can see one interesting element. You can see at the top, you can see the burden of the admissions to hospital, and then you see below, you can see the in-hospital mortality. And you can see a very clear relationship between a decrease in occupancy rate and a decrease in mortality. Now, I reported some elements there of the results, which we all found interesting discussing in preparation for this meeting. But essentially, you can see that disease severity and comorbidities accounted only for about 10% of this reduction in mortality. And respiratory support and the use of steroids accounted only for 22% of this reduction. So around 32% of this reduction was accounted for, but the majority, almost 70% of this reduction, was unaccounted for. And a possibility was a variety of reasons, including hospital capacity strain. So if you go next, please, Maria. Now, this is quite interesting, but it requires a little bit of getting used to. But if you follow the left-hand side, the one in green, so that you can see is the hazard ratio of mortality, or sorry, the odds ratio for mortality when you compare an occupancy rate between 0 and 45% compared to a 45 to 85%. And you can see when the ICU are relatively empty, then you can see that the mortality decreases. You can see the odds ratio for mortality is about 0.8, so less than 1. Whereas when the occupancy rate goes up, so about 85 to 100%, compared to 45 to 85%, the odds ratio go up close to 1.2. So there's a 20% increase or decrease depending on whether the occupancy is below or above the range. Now, the one I found also interesting is the one on the right-hand side, and you can see that the possibility of dying increases if the occupancy rate is very high at the time when the patient is admitted, at the top right. In the middle, where the occupancy rate is high throughout the hospital stay of that particular individual patient. And also the one at the bottom, you can see that there is a higher risk of dying on the day when the occupancy rate is much higher. And that has to do with particularly sort of human factors, decision making, and strain in the ICU. You go next, please, Maria. So this is one from the UK, and I would like Ed's opinion on that as well, because obviously it's been very close to his own experience. But what you can see here, you can see the curve on the left-hand side. You can see when the number of patients is above the 100% occupancy rate, you can see there is a very different mortality outcome. And if you look on the table, you can see that if the occupancy rate is less than 25%, you can see a very low mortality, 14%, which increases as the occupancy rate approaches 100%. So you can see huge difference between 14 and 33%, and in ICU between 28% mortality when there is low occupancy rate and about 66% mortality when the occupancy rate is above 100% baseline. But Ed, we all would like your input and discussion about your experience about that in the United States. I think you might be muted, but that's a common issue at the moment.
Luigi, can you hear me?
Yes, we can. Thank you, Ed.
I'm not sure what audio I'm running through. I think it's not sure. Now I can't hear. All right, assuming you guys can hear me. Looking at this table, I think what I learned and I can assimilate for the case of Cleveland Clinic, Florida. For those that do not know the context of Cleveland Clinic, Florida business, we are a small hospital, 255 beds, where we do liver transplants, heart transplants, and very high-risk surgery. We are the smallest hospital compared to the local market. This is Baptist, this is Memorial, Broward Health. Those are big sharks in the tank. We are the small fish. So to some degree, we were protected as far as census and occupancy because the big hospitals were taking the biggest amount of patients once they were full, and their spillage, all the patients they couldn't take care of, eventually end up with us. We are small, so our dynamics was quite different. So we quickly got to a point where our capacity was, at the top. But we are very much used to that, being small with a lot of business. We run our capacity quite usually beyond 100%. That's hospital-wide. As far as the ICU, our capacity is usually 80 to 90%. So for us, adding COVID patients was really quite a challenge. And I'm sure that most of you have experienced, at least in the States, the loss of staff, with COVID dynamics and agency nurses paying a lot more, probably 3 or 4, 5, 10 times more of what a salaried nurse makes in an ICU. We started experiencing more patients with less amount of providers. I think to some degree we saw that reflected in the months of between October, November, and December, perhaps, where our mortality went up a bit. Unfortunately so. But ever since then, since we adjusted the business model, we were able to adjust the care and our mortality came down. So I couldn't really tell that, the graph shown here is pretty much aligned with what we see in the real clinical work.
Can you guys hear me? This is Nadeem from Abu Dhabi. We have had some issues. I don't know if can you hear me okay? I know you can't see me.
I can hear you okay.
Did you want to add? Did you want to add something, Nadeem? Sorry,
Yes. I just interject, Nadeem. I'm really sorry, it's George, that we couldn't make that work. And I'll just gonna mention that both you and Vivek are very tired because you did your first successful awake ECMO retrieval in the Gulf, which is obviously great in a COVID patient.
It's probably better you don't see me then. So we actually, I mean, Vivek won't say it, but I'll say it for him. He's led our ECMO team. We have, I don't know, I know you've met Jihad, Jimmy, Fadi. I'm blessed. We have God bless a wonderful team here. And real quickly, I've been with the Cleveland Clinic for 21 years. I'm born and raised in Cleveland, Ohio. I've done my residency, fellowship, medical school there. I was at Cleveland Clinic, Florida. Ed Nagar and I were classmates. I know Abhijit well. I know all the MICU guys. So it's truly a blessing to sort of have this universal CCF. I don't think anybody's prouder of it than I am, just because being with the system for 21 years and just what we've done out here is 72 beds. We went to 130 during the pandemic. In our second wave, after, you guys know, being a Muslim country after Eid, we had our second surge where we went back to a COVID ICU. Mortality was actually less. We doubled the amount of ECMO patients, obviously a little bit sicker, so our ICU length of stay was also longer. But given everything that we've done in sort of in similarity to Western Florida, we're about close to, I want to say 370, 380 bed hospital with probably almost 32% critical care beds, which is truly amazing. So we are truly the tertiary quaternary care, not only of the UAE, of the Emirates, for the GCC as well. And hopefully we're going to expand. We have an oncological institute opening up in a year. And God willing, we should be over 110 beds of a 400-bed hospital, which is truly insane if you look at the numbers. So that being said, we've learned a lot. This has been great. I just want to say thank you for this. And I just can't wait till we do more things like this in collaboration. And truly, we're the only healthcare system literally in the world that could pull this off. So that being said, I'm going to stop and let everybody take it from there. But thanks for the opportunity. Look forward to meeting you guys in person one day.
Luigi, I think you are muted.
You were muted after I stopped.
Sorry. I was just going to say, I was just thanking you, Nadeem, for your intervention and for being with us. And at the same time, I think you alluded to a very interesting point, which is one of the issues with these trials or studies that we presented is that don't adjust for the case volume at baseline. So, and we know that case volume relationship is very important. So the way that you can stretch if you're a high volume center is very different to other low volume centers the way they can adapt. But I think, Abby, you're going to go next because you've got very interesting thoughts around a interesting study. So next, please.
Thanks, Luigi. So I just wanted to talk about this study that was done by Matt Churpak. They took the stock data from about 40 US hospital systems and looked at the variation in death based on hospital level variables. So if you look at this graph, this is pretty interesting. What they did was that they basically took patient level data and then looked at how they can adjust for patient level data in terms of the random effect of where a patient gets admitted in terms of the hospital that they were admitted in, the physiological aspects, which really were severity of illness and the acute aspect of COVID infection itself, the demographics and comorbidities for these patients, and the treatment options that these patients were provided. So what they did was that they took all these variables and sequentially adjusted for the effect of these things at the patient level. Once they did that, they moved forward and looked at the socioeconomic strata of the patient population and the area where the specific hospitals were located in, the strain that the specific hospital was meeting, which is, I think, a very cool way to look at this, because as we know, like strain, especially across the US, was never constant. Like there was a huge geographical variation in terms of which areas were really being exposed to high stress or strain situations. And then the other thing that they did, which I think is very interesting, is that they took the quality metrics for these hospitals and adjusted for that. And that for people who are not in the US really is that, like, what they took away from that was that they looked at how well these hospitals were performing in key quality metrics at baseline before the COVID pandemic, and really adjusted for those. Next slide, Luigi. And this is the outcome that they saw, and this is pretty interesting. So what they saw was that if you broke things down into these nice bins, what is the attributable effect on mortality of these specific things? So about 50% of the mortality was really driven by the physiological aspects, which is a little bit different than what Luigi presented before in the UK cohort. So in the US cohort, we saw a huge impact of physiology and the demographics and comorbidity. But for me, I think the most interesting thing here is that the hospital level effect was pretty significant too. Not only was the hospital strain impacting the outcomes, but where these hospitals were located and their baseline quality metrics had a very important impact on the outcomes of those populations. Once they addressed for these all factors in this cohort of patients, the treatment effect was only about 3%, which is very, very, very small. And this really brings about a very important question for us to think about, which is there a huge impact of things if we are not standardizing of care, like standardizing the care for these mechanically ventilated patients? If we have severe variability across different healthcare systems, do we see a huge impact on outcomes independent of whatever treatment they are being provided or not provided? Luigi, if you can go to the next view, if you can click. Yeah. So I think when we think about standardization of care in mechanically ventilated patients, there's so many factors where there could be hospital level variation. When do they intubate these patients? Are they really using like evidence-based medicine and lung protective ventilations? How do they define optimal PEEP? What's their sedation strategies? Like, do they look at vent synchrony and work on those? Next, please. And what do they do with their adjunctive therapies? When do they consider proning people? How often do they think about proning people? And then eventually, where is the time for getting these people on ECMO? So these variations can have huge impacts in healthcare systems where there is no, or where there is significant variability. So one thing that we really need to kind of think about as we think about the overarching things in these patients is that we need to be consistent. We need to make sure that everyone adheres to the best available evidence, and consideration to escalation of high volume centers really to make sure that you're achieving these standard of cares in a better way should be thought about. And unless these all factors are met, data is always going to be erroneous, because if you have data that has significant variability, it's going to be very difficult for us to have meaningful outcomes from that data.
Thank you very much. We were just wondering, because if we, very interesting the data that you presented, and clearly points the fact that obviously there is a lot of scope for standardization and just maximize the benefits that we can get from treatment. But clearly there are a lot of other things, you know, the one you pointed out, the comorbidities, the inequality of access to healthcare, the social determinants of health, the type of population. Was very interesting, the analysis that showed that essentially being 45 minutes away from your place of work essentially increases your chances of poor outcome. So I don't know, Ed and Abby, what do we think about prevention strategies, or some? It looks like it's a healthcare policy issues to bring down that mortality, as well as what we can do in the intensive care. But that was my thoughts reading this paper. But I'm very interested to hear yours.
So Luigi, this is Ed. You know, I totally agree with Ab in the sense that, you know, when we allow variability and when we are forced to allow variability, when, let's say, we are losing nurses, we are losing respiratory therapists, and the only ones that we can hire are agency nurses or agency RTs, it really puts an even higher amount of strain to the staffing model and to the hospital, you know, capabilities. So have I seen cases in which the respiratory therapists who are agency, you know, hopefully they went through the vetting system and so they don't do as well as our own employees? Yes, believe me, it does happen. They don't have the same type of commitment to the institution. So if there is something that I think we learned, at least in Cleveland Clinic, Florida, is that for the next time, when we are going to be strained like this, we really need to quickly adjust our business model so we can retain our talent, the people that we have trained and we have worked for a long time, because they know how we work, they know our protocols, they know our standard operating procedures, and it is really hard to trust somebody else from you know, another hospital to come and do the quality job that we do in the Cleveland Clinic. So
thank you so much,
yes,
Ed. Abby, thanks, Ed.
Thanks,
Abby,
Ed.
very quick last comment before we give
I completely agree with you, Luigi. I think this is a public policy. It's a public health issue. I think, like, you know, we can do everything that we want to in the ICU setting. We should not be needing to do these things. Like, it's a failure when public policy fails in terms of primary prevention. We didn't have the option during the first few waves because we didn't have the vaccination. Now that we do, I think every effort should really be put forward towards primary prevention, so that we don't really have to come in and really try to do the things that we have to do when those things fail.
Thank you, everyone. George, over to you.
So thanks a lot. I think we've had another fascinating and very inspiring and interesting, thought-provoking session. Let me not only thank the panelists, but also the delegates for holding out that long. We've thankfully not drawn over too much. We've got obviously another half day tomorrow. Again, I re-emphasize, if people would like to register, they can always access the recordings at a later date. I think it will be a very interesting day again tomorrow, with lots of insights into therapies, ECMO, transplantation around COVID, mechanical ventilation, but then also qualitative staff welfare, post-traumatic stress disorders and the likes talks, which the human factors are clearly immensely important. So I'm handing over briefly to Nick now to close the day, and I hope I'm going to see many of you tomorrow. Thank you so much for your participation.
Thank you so much, George. I get the easy job. I got to open it and I got to close it without presenting any slides today. So again, thank you very much to everyone. You've invested so much time in this disease. You've invested so much time in this conference. You've shared your experience. I can see 1,000 conversations being launched and some great relationships may be forming across the Cleveland Clinic enterprise. One thing I really have to do is to thank Maria. Everyone's been saying next slide, Maria, all day. Maria has been at least half a second quicker than the queue. So thank you so much, Maria. She hasn't taken a break and she's been spot on. So we owe you definitely gratitude. So thank you very much. For those who are coming tomorrow, it's a 1 o'clock start, 1 o'clock London time. if you're able to take time out of your families just to join us for a bit, it'll be absolutely wonderful to see you. It's not too late to register. I'd like to say good evening or good afternoon, depending where you are, and we hope to see you tomorrow.
Goodbye.